Good afternoon, everybody. Hello. This is Dr. Indranil. Am I audible?
Yes, you are.
Yeah.
Okay. Yeah, I'm just waiting for Dr. Paramashwara to join. Then we will start the proceeding. Can you just show the first slide first from the very beginning? Go to the first slide, the title slide, Professor V.K. Grover's slide.
Good evening, sir. Shall I ask you one doubt, sir?
Yes, tell me.
Sir, we were informed that the presentation is 7 minutes plus question and answer session 2 minutes. So we have sent the video
Yes.
as 7 plus 2.
Yeah.
It's been shown here as 5 plus 2. That's why I got the doubt.
Okay, no. That must be a typographical error. Don't worry. I'll announce everything just now.
Okay.
Just give me some time. Yeah.
Thank you, sir.
Cubics people, please go to the first slide. Yeah, good afternoon, everybody. I think we are in high energy mode after lunch at our respective places. So I'm very sorry we could not provide the sumptuous feast which is happening in the country because of the online program. So we are starting the very important competition section of ISNACC, that is Professor V.K. Grover Memorial Award presentation, paper presentation. This is a competition section comprising of only original research articles. The judges for this section will be Professor Amna Goswami, Professor G Paramashwara, and Professor Pragati Gadgi. Can you just show the slides, please? Yeah. So I'll just tell you something about these three excellent and great people. The slide on Professor Amna, please. So as we have seen in this Professor Amna Goswami is a graduate from Medical College and illustrious career at the Bangalore Institute of Neurosciences. And after retirement from health services, she has joined the Park Clinic as consultant neuroanesthetists, where she is attached till date. And she is the coordinator of the PDF, ISNACC PDF program in neuroanesthesia at Park Clinic. And obviously, she had been a past president of ISNACC. Next slide, please.
Hello, Amna ma'am. Good afternoon, ma'am.
Hello.
Yeah.
afternoon. Good afternoon. Nice to
Professor
see
G Paramashwara is a senior consultant anesthesiologist from Manipal Hospitals, Bangalore. He needs no introduction. He was MBBS from BMC in 1975, did his MD from All India Institute, New Delhi. Then he was associated with the National Institute of Mental Health and Neurosciences, Bangalore. He has been awarded with many honors. He has been the past president of ISNACC, past secretary of the Indian Society of Neuroanesthesiology Critical Care, past governing body member of ISA, secretary ISA Karnataka State Branch, president ISA Bangalore City Branch, secretary Indian Society of Anesthesiology Bangalore City Branch, and obviously he has attended and presented papers in many international conferences. Next slide, please. Yes, now we come to Professor Pragati Madam, Pragati Ganju. She also doesn't need any introduction. She is presently the director, professor and head, Department of Anesthesiology, Intensive Care, head of Neuroanesthesia Unit, and she is a program coordinator of Diplomate in National Board, Neuroanesthesia and Critical Care Program, which is running at very successfully at Shivananda Institute of Postgraduate Medical Education and Research and Maulana Azad Medical College, India. Next slide, please. So the original articles which were submitted for selection in this section were scrutinized by a panel of experts nominated by the organizing committee, and we have collected the best original articles from that group. You must be knowing it because it was already conveyed to you beforehand. So I'll just reiterate it. The presentation is of total 9 minutes, out of which the presentation duration will be 7 minutes and the question answer will be of 2 minutes. So I think it will be a hybrid type. Some of you have been able to send the video of your presentation and the others will go live. Next slide, please. Yes, so these are the presenters. This is a random order. So we have got how many? Dr. Balajit, Dr. Pramod Kalgudi, Dr. Gopalakrishna K.N, Dr. Salini R Varma, Dr. Nirupa, Dr. Gautham Nodu, Dr. Jithumol. Next slide. Dr. Dhokte, Dr. Sourav Barman, Dr. Charoo Negi, Dr. Priya Thapa, Dr. Ramamani Mariappan, Dr. Shyamala, and Dr. Mouleeswaran S. So this is the list of the presenters for this year's Professor V.K. Grover original research article presentation. So may I request the first person who is in that order to start presenting. Thank you.
Just a minute, Indranil, just one query.
Yes, madam.
Yeah,
Yes, madam.
You said something about marking. I think, I mean, are the presenters aware of it? There is a negative clause to the timing, you know, so they need to stick to the time. So are they aware of that?
Yes, yes.
We know it.
Yeah.
I'm not spelling it
Yes.
out. They should also know. And I think it would be good if the organizers take note of that, because it may not be possible for us to, you know, keep looking at it. Of course, we will. The timer is
okay,
there.
madam. Okay, madam.
Yeah, that's it.
Yeah.
Okay.
Thank you, madam. The mark sheets are all with you, madam. So you can put your marks. After that, you get the thing scanned and send it to us for the final calculation.
We'll do that.
Okay, madam. Thank you.
Excuse me, sir.
Huh. Tell me.
Sir, actually, my name has not been announced. I was also for this category. I have sent the video also.
Yes,
Dr.
yes.
Sapna Suresh.
Yeah. You must have sent your original research article, right?
Yes, sir.
Yeah, actually, we have those who were not selected in this V.K. Grover section.
Dr.
We have categorized them in the
National Institute of Mental Health and Neurosciences.
Just a minute. Please hold on.
I'll be presenting my study entitled
Please stop the record.
Rapid insufflation
Hello.
of ventilator exchange.
Please stop the video.
Technique for oxidation in patients undergoing electroconvulsive therapy.
Yeah. So, Dr. Sapna, are you there?
Yes, sir.
Yeah. So, out of all the original research articles sent to us, we have selected these group our panel had selected. The rest of the people who have sent their beautiful original research articles, they are in the group of free paper.
Sir, but mine was under VK Grover itself. They sent me this link also, and they sent me the V-transfer thing also.
Okay. So your name is not here?
No, sir. My name and the video is not here.
So do you have the video with you right now?
Yes, sir, I have the video with me.
Okay.
I sent it in the info ISNACC Gmail also. If you want, I will resend it.
Yeah. So what you do is you can show it in over here only. There is no issue, no problem.
Sir, can you just verify whether my name is there?
No. I just check. Let the thing continue and.
Yeah. Okay, sir. Okay.
No issue. So I think we can start the first lecture.
Sir, we are starting with Dr. Balajit. Dr. Balajit V.
Mental Health and Neurosciences, Bangalore. I will be presenting my study entitled
Please start the video.
Effectiveness of hands-free, transnasal, humidified, rapid insufflation ventilator exchange, THRIVE, over the conventional face mask ventilation technique for oxygenation in patients undergoing electroconvulsive therapy, a crossover study. Electroconvulsive therapy involves pre-oxygenation with 100% oxygen, followed by the administration of short-acting intravenous agents and short-acting muscle relaxant. The patients are ventilated by bag and mask technique that is interrupted briefly during the application of the electrical stimulus. THRIVE can deliver very high flows with the provision of dynamic positive airway pressure that can safely sustain apnea in short procedures like electroconvulsive therapy. The main hypothesis of the study was to prove that THRIVE as a sole insufflation technique is non-inferior to the conventional bag and mask ventilation technique during the conduct of electroconvulsive therapy. The primary objective was to find the incidence of oxygen desaturation in patients receiving oxygen supplementation by THRIVE technique and the conventional face mask ventilation technique during ECT. Comparison of hemodynamics, seizure duration, type 2 awakening, and any airway complications in terms of nasal trauma, hoarseness, pneumothorax were additional points of interest between the two groups. This was a single-center crossover study which was conducted at Emergence, Bangalore between December 2020 to August 2021 after the approval from the Institute Ethics Committee. A total of 201 adult psychiatric patients who met the inclusion criteria between the 3rd and 5th ECT session were enrolled for the study. The study was registered with the Clinical Trial Registry of India. Inclusion criteria included adult psychiatric patients between the 3rd and 5th ECT treatment session, ASA physical status 1 and 2, age between 18 to 50 years, and BMI of less than 40 kg per meter square. Exclusion criteria: patients who are incapable of giving consent, ASA physical status 3 and 4, patients with severe comorbidities like congestive heart failure, ischemic heart disease, patients with baseline oxygen saturation of less than 95%, difficult airway, Mallampatti airway class 3 and 4, and patients who required second stimulus due to inadequate seizure duration after the first stimulus application. Face mask group, pre-oxygenation was done with 6 liters per minute of 100% oxygen with normal tidal volume breathing for 3 minutes. Induction was done with intravenous thiopentone sodium in a dose of 1.5 to 2 milligrams per kg, and the patient's breathing was assisted with bag and mask ventilation. After isolating the lower limb with the NAP pickup, succinylcholine in the dose of 0.5 to 1 milligram per kg was administered. And following the cessation of succinylcholine fasciculation, a bite block was placed. The amount of charge and placement of electrodes was determined by the attending psychiatrist. The motor seizure duration was recorded. Following the complete cessation of the motor seizures, bite block was removed and oral suction was done to clear the secretions, and the patients were assisted with bag and mask ventilation until they regained their spontaneous breathing. The course of the procedure was same in the THRIVE group as the face mask group. In the THRIVE group, a lubojaw collar was applied awake after explaining the procedure, and the patient were pre-oxygenated with THRIVE flows of 30 liters per minute for a period of 3 minutes. Following the anesthesia induction with thiopentone of 1.5 to 2 milligrams per kg and succinylcholine of 0.5 to 1 milligram per kg, thigh flow was escalated and maintained at 50 liters per minute during the apneic phase, during the ECT stimulus application, and during the subsequent seizure period. Once the patient regained the spontaneous breathing, thigh flow was de-escalated every minute by 10 to 20 liters. Oxygen saturation was monitored throughout the procedure, and a saturation of less than 92% was termed as a desaturation event in both the groups. Intervention with bag and mask ventilation was planned if oxygen saturation dropped below 90% for 30 seconds or less than 85% irrespective of the duration. In both the techniques, baseline saturation, heart rate, systolic, diastolic, and mean arterial pressure were noted. Saturation were noted every minute starting from the baseline for a period of 10 minutes till the completion of the procedure. Hemodynamic parameters were noted at 2 time points, time point 2 and time point 5. Time point 2 is the 2 minutes after the application of shock therapy, and time point 5 is the 5 minutes after the application of shock therapy. Seizure duration were also noted in both the groups. Time to recovery was noted, that is from the cessation of the last motor seizure activity to the first conscious verbal response to command. All the patients in both the groups were followed for 24 hours post ECT for any airway complications like nasal injury, nasal bleed, hoarseness, pneumothorax. This was the scenario in the thigh group. A Lubo airway collar was applied awake after explaining the procedure to the patient, and the thigh flow was started at 30 liters per minute for a period of 3 minutes, free oxygenation. And following the administration of intravenous anesthetic agent and muscle relaxant, the flow was escalated to 50 liters per minute, and it was maintained throughout the procedure till the recovery of spontaneous breathing. And this video shows the conduct of the ECT with the thigh and the Lubo airway collar in situ. Statistical analysis was performed using R software. Quantitative data was presented as mean standard deviation, while the nominal data was presented as frequencies and percentages. Statistical difference of discrete data between the groups was tested by PAT test. Longitudinal data differences between the groups was tested using linear mixed effect model, and the p-value of less than 0.05 was considered statistically significant. Results: the mean age was 31.5%. Majority of them were male patient. Mean BMI was 23.4 with a standard deviation of 3.8. Majority of the patient belonged to ASA class 1, 71%. And majority of the patient had a Mallampati grade of class 2. Oxygen saturation. There was one desaturation event in the thigh group, and there was no desaturation event in the face mask group. And this table shows the mean SpO2 between the groups over the time points, 10 time points. 0 is the baseline, and 10 is the till the completion of the procedure. The mean saturation increased from baseline in both the techniques, both the face mask and thigh group. The mean saturation increased from baseline, but the mean saturation was slightly higher in the thigh group compared to the face mask group. The thigh group had a mean saturation of 99.45 with a standard deviation of 0.3, and the face mask group had a mean saturation of 99.41 with a standard deviation of 0.3. This table shows the analysis of SpO2 change by regression model. So as I mentioned, the mean saturation was higher in the thigh group at all the 10 time points with a statistical significance, except at time point 1 and 6, in which there was no statistical significance was found. This table shows the mean map between the groups over the 3 time points. 0 is the baseline, 2 is the 2 minutes after the shock therapy, 5 is the 5 minutes after the shock therapy. So the mean arterial pressure increased from baseline in both the groups, and the mean arterial pressure in the thigh group was higher compared to the face mask group by 0.9 millimeters of mercury without any statistical significance. We found a statistical significance at time point 5, in which the thigh group had a map of 9.1 millimeters of mercury higher when compared to the face mask group by regression model. This table shows the mean heart rate between the groups over the 3 time points, and the mean heart rate increased from baseline in both the groups. The mean heart rate in the thigh was 1.5 beats per minute higher compared to the face mask group, and we found a statistical significance by the regression model at time point 2, in which the mean heart rate was 8 beats per minute lower compared to the face mask group. ECT parameters, since it was a crossover study and the same patients were exposed to the two different techniques, the stimulus parameters, dose of intravenous anesthetic agent, dose of succinyl choline were same in both the techniques. Seizure duration was slightly higher in the face mask group compared to the Thrive group, but there was no statistical significance, which was tested by PAT test with a p-value of 0.05. Time to awakening, there was also no statistical significance between the two groups with a p-value of 0.1. There was no complications in terms of nasal injury, hoarseness, or pneumothorax in both the groups. Study limitation, we did not perform the measurement of carbon dioxide by any means. Since carbon dioxide accumulation can be a concern during the application of Thrive, there are a lot of studies which have done the measurement by transcutaneous carbon dioxide monitoring, but our institute didn't have this facility of monitoring carbon dioxide by transcutaneous monitor. So we didn't perform this monitoring, but even though we didn't face any complications since ECT was a short procedure, to conclude, Thrive is a non-inferior to the conventional bag mask ventilation technique in ECT. Thrive can safely sustain apnea in ECT as a sole anesthetic technique, and Thrive can have possible operational advantage in the hands of non-anesthesiologist in the ECT suite. Thank you. Hello all, this is Dr. Balajit Vaidilingam from National Institute of
Question answers, please.
Pragati, you want to ask a question?
Yeah, Dr. Balajit, first and foremost, what made you think that, what are the advantages? Like, why do you think this is a good agent for a good system for the ECT? This is not holding the airway is one of the major problems when you give ECT to your patient. And this, I mean, nothing, appears better than holding the mask yourself and also pulling, keeping the airway intact. And so you have any issues with that, and then you thought of bringing this in?
No, it was basically the study basically to test the feasibility of the Thrive in ECT. So as of now, we didn't have any concern with the face mask, but we wanted to test the feasibility of this technique ECT. One important thing is that if this technique works out very well in ECT, then definitely it will be a total hands-free technique. Anesthesiologist no need to touch the patient.
Excuse me, you used it in Mallampatti 1 and 2 patients, near normal. Yeah. So do you think this will hold when you have a variety of patients, like with the different?
That's not we have to test that. We have not tested in difficult airway patients. So we just wanted to test the feasibility in normal patients. If it works out well in normal patients, we can do it in the future.
Have you used it in any other? Have you used it elsewhere in any other kind of setting?
I have used in one pregnant patient, 6 months pregnant patient. I have included that patient in the study also, and she was 6 months pregnant patient, and I was
Which patients? Which patients?
Pregnant patient, on 6 months old pregnant patient.
Okay.
She was diagnosed with case of acute psychosis of pregnancy, and she was posted for electroconvulsive therapy during the 6 months of pregnancy. So since pregnancy is a state of risk of aspiration during bag and mask ventilation, so we tried to apply this Thrive technique, and we succeeded in this patient also.
Okay. Anyone else?
Balaji, just like the previous question, just as a corollary to that, what extra advantage apart from the fact that you don't have to hold the mask by the hand? You feel
one more thing that
extra advantage.
One more thing which I want to specify is that our center ECT is a lot of patients we do on day-to-day basis, ECT cases, and very often anesthesiologists are called to administer anesthesia. And if this technique is very simple, and even a non-anesthesiologist can operate it, just it's not mandatory that the anesthesiologist has to be there while the conduct of this ECT with the help of Thrive. So this 2 to 3 cases I have tested with by a non-anesthetic psychiatric person, and he was very much able to do this technique. We were standing on the side. And
beg to differ a little here. What Dr. Amna is saying is that basically you were lucky. You went away. You were kind of scot-free. You didn't have face any airway problems.
Theoretically, it is very wrong.
ECT is a dangerous procedure. It's a small procedure, but it has airway issues. And
Exactly.
handing it over to a non-anesthetist, I'm not sure if it's such a good idea.
Only in patients with normal patients with a normal airway, ASA 1 and 2 patients, it's very much applicable. In abnormal patients with severe comorbids or difficult airway, it's not a good idea.
So handing over to, I mean, if you use this as a this thing context that a non-anesthetist can give it is something which I am strongly against. I mean, this
medico-legally it will be thoroughly wrong.
Yeah. But otherwise, you can say that you want to have a hands-free thing, and more hands-free things are coming up. Like we are trying, so that can be an added advantage of this. But please don't say that you replace the anesthetist with this, because that is not acceptable.
Okay.
Okay.
Parameshwar, anything you want to ask?
You are muted, sir. Sir, you are muted. You have to unmute.
The duration is hardly about 10 minutes. So it really doesn't matter whether you use a face mask or a trach, and the flow rate which you have is required for the trach is very, very high. And what is the flow rate which you use when you use a face mask?
6 liters per minute I use.
No, for face mask, 6 liters.
Face mask, 6 liters per minute.
Yeah. So the difference is quite vast.
So oxygen wastage is one concern, more concern. Wastage of oxygen.
Yeah, that is one aspect. See, thrive is generally more useful if you have a prolonged procedure, at least about 15-20 minutes, where there is going to be significant change as compared to this face mask ventilation. Probably, yes, we can take this thing. You did pre-oxygenate the patients in the face mask group?
Yes, yes, sir.
You did that one. Okay.
6 liters per minute for 3 minutes.
Okay.
I think
that is all I want to ask for you.
Move to the next one. And organizers, who's keeping time? I'm not keeping time, so I hope somebody's keeping time.
No, we are seeing the time, sir, madam. We are seeing the time.
Okay.
Next one. Yeah.
I think
Dr.
at the end of
from Imans Hospital, Bangalore. I'm here today to present my research titled Correlation of Pre-Operative Hippocampal Volume Measured with Magnetic Resonance Imaging and Duration of Emergence from General Anesthesia in Elective Neurosurgical Patients. Emergence from anesthesia occurs in bottom-up fashion. That is, upon emergence, initially the subcortical structures and the limbic regions like hippocampus gets activated, and eventually the cortex gets activated. The functional reserve index consists of components like education, working profile, and leisure activities, and these components determine the existing functional reserve of the patient and contribute to behavioral characteristics. The objectives of our study were to evaluate the correlation between preoperative hippocampal volume and functional reserve index with duration and pattern of emergence after general anesthesia. This study was conducted in our hospital over a period of 2 years. This was a prospective observational study, including patients greater than or equal to 18 years with preoperative MRI brain and a GCS of 15, and excluded the ones who had temporal lobe pathologies and hippocampus and amygdala excision. This study was funded by Indian Council of Medical Research. Apart from routine pre-anesthetic evaluation, we calculated hippocampal volumes and total brain volume using MRI preoperatively and calculated FRI using a questionnaire consisting of questions pertaining to education, working, and leisure activities. The emergence characteristics were noted as phases of emergence and patterns of emergence using GCS and Riker sedation agitation scale at various time points from the point of turning of sevoflurane, and further classified as smooth emergence, agitated emergence, and sedated emergence. We calculated preoperative hippocampal volume using T1 MP-RAGE brain sequence with the help of MATLAB's FSL and ITK SNAP softwares. And we standardized these hippocampal volumes with that of total brain volumes, which were calculated using computational analysis toolbox. We standardized the anesthesia technique by using sevoflurane and vecuronium in all of our patients. And at the end of surgery, the MAC was noted and the neuromuscular blockade was reversed once stop count was equal to or greater than 3. Sevoflurane was turned off and the fresh gas flow of 6 liters per minute was set, allowing patients to wake up using no contact technique. Time duration from the point of turning off sevoflurane till the onset of different phases of emergence were measured. The statistical analysis was done using software R, and correlation between hippocampal volume and emergence parameters were done using Spearman's rank correlation. We recruited 1,192 patients, and a complete data of 125 patients were collected and analyzed. 100 patients underwent intracranial surgeries, 25 patients underwent spine surgeries in these 125 patients. These are the demographic profiles of our study population. The median age of our study population was 41 years. The median average of standard hippocampal volume was 2,249.16 millimeter cube, and median years of FRI education was 9 years in our study population. These are the time taken in minutes for the onset of different phases of recovery after switching off of sevoflurane. The median extubation time was 13 minutes with the interquartile range of 9 to 16 minutes. We found significant negative correlation with average standard hippocampal volume to that of orientation, vocalization, and extubation, whereas we found significant negative correlation with dominant standard hippocampal volume only with orientation and extubation. But we found significant negative correlation with most of the phases of emergence with FRI education. ROC was constructed for predictive accuracy of hippocampal volume for dichotomized extubation times with time greater than 9.2 minutes as delayed and less than 9.2 minutes as normal extubation. And we found volume less than 2000 millimeter cube for standard average hippocampal volume and volume less than 1,920 millimeter cube for standard dominant hippocampal volume predicted delayed extubation times with specificity of 90.6 and 87.5 respectively. We found significant positive correlation with average standard hippocampal volume to GCS greater than 12 in our study population and significant negative correlation with FRI education and RICA less than 3. The previous studies done so far have shown that repeated exposure of sevoflurane leads to reduction in volume of hippocampus in rodent, whereas it has also shown that patients with post-operative cognitive dysfunction had significant smaller hippocampal volumes. But none of the studies done so far have predicted pre-operative hippocampal volumes correlation to that of emergence. So in contrast to above studies, we studied brain and hippocampal volume before the study subjects were exposed to anesthetics. And we found patients with higher hippocampal volumes remained more conscious and led to earlier extubation and gaining orientation after switching off sevoflurane. And patients with higher years of education had faster recovery in various recovery parameters, and patients with higher years of education were less sedated during recovery in our study. So these findings can be explained in consensus with this theory that better brain reserve capacity would help for faster emergence from anesthesia. Smaller sampling volume and study population, including predominantly neurosurgical patients, and these study population findings may not be reflective of the population who are not having intracranial pathologies, are few of the limitations of our study. Thus, to conclude, neurosurgical patients with larger hippocampal volume led to earlier extubation, vocalization, and faster gaining of orientation after general anesthesia. And educated neurosurgical patients tend to have faster and smoother emergence from general anesthesia. Thus, knowing preoperative hippocampal volume and patient's educational status would assist to anticipate the duration and pattern of emergence from general anesthesia. However, further studies are required to elucidate the role of other deep gray matter structures in anesthetic emergence and effect of different anesthetics on patient outcomes. I thank organizing committee for giving me this opportunity. Thank you one and all. Good evening, everyone. I'm Dr. Pramod from Nimans Hospital, Bangalore.
Yeah, now it's time for question answers.
Pramod, this measurement of the hippocampus, was it done separately? An MRI was done separately for that, or was it the routine investigations in a brain case?
Thank you, ma'am. Thank you for the question. The MRI for most of the patients who underwent brain surgeries were already done beforehand by the neurosurgeons for the sake of pathology itself. And for the spine patients, the MRI brain was not done. So the ICMR grants were utilized to get an MRI brain in these patients, especially T1 MP-rate sequence alone for calculation purposes.
It was part of the routine, not a separate MRI for just
no, not separate MRI was done. Only in spine patients, the money was used to get the MRI done from the IC.
Right.
See, in your study, you
Yes,
have said the age group of patients from 18 to how much?
So greater than 18, greater than or equal to 18.
Correct. But there could be a difference between patients who are, say, less than about 30, 40 years and more than that. You might have included those groups also. Will that make a change in the cognition and the recovery and all that? Doesn't it make a difference?
Sir, just because the hippocampus might change in the volume based on the age group. So that is the reason why we standardize the hippocampal volume for a respective patient. Suppose a aged person having a shrunken brain will have a shrunken hippocampus. So the volume of hippocampus was calculated with respect to his own brain.
So you took the ratio of the
ratio of hippocampus to the whole brain volume, so that we standardized each of the hippocampal volume respect to each of these patients. So in that way, we can negate the effect of age and the age factor in that.
No, but that actually adds more problem. Basically, if the volume of the brain has shrunken, it means that he is getting more and more demented.
Yes, sir.
Don't you think that that affects the recovery?
Yeah, it might, sir. It might affect the recovery, and it will affect the recovery, sir. But we have the median age was around 41. We didn't have much of the age group more than 60 years in our study.
Okay.
Do you think this will be very important clinically? Clinical application, just measure the hippocampus to see the recovery rate of a patient?
Yes, ma'am. Thank you for the question. Because in neurosurgical aspect, when we think of a patient who is having delayed recovery, it is better to get an anticipation of how the patient will recover or when the patient will recover beforehand. So if at all a patient has an MRI brain prior to the surgery, there is no harm in calculating the volume, which is just a software based. And if at all the patient has a delayed recovery, we can even give it will at least give us a clue that it might be because of a smaller hippocampus, and we can further evaluate for other causes for delayed recovery as well in such patients.
Pramod, I want to ask you something. You use the word education. You think education is the right term or intelligence is the right term? Because
ma'am,
thank you for the IQ.
Yeah, ma'am. It's based on the IQ, but the questionnaire which we followed is also been used, and it's for cognitive functions of a patient. So they have considered the years of education and the degrees of education. That is the higher.
You have very bright people who may not be educated, so that doesn't, yeah. I mean that's what, so that sort of takes it away. And second thing is, are we worried more about POCD or are we worried about emergence? Because emergence is determined by multiple factors.
Yes,
the kind of anesthesia and the experience of the anesthetist and the drugs that you choose. Of course, you have kept the same across the thing, but in clinical practice, as Dr. Amna was saying, are you with the references that you've given? They were more about POCD with the hippocampal volume. They were kind of kind of correlating. So are we worried here about emergence, because that's not such a big deal? Even if how much is the emergence delay? Like you can handle that, but what you can't handle is, or you find it difficult to handle, is POCD. So if that gives you a clue, then it would be a useful thing, not just emergence.
Ma'am, all the studies done so far were done with respect to POCDs, because they have done post to the surgery. The MRIs were done prospectively in the patients who had POCDs. They did an MRI, and then they found that they had a smaller hippocampus. So the correlation was done later that because of the smaller hippocampus, they had the POCD. But in our study, we did it prior to the exposure to anesthetics to predict the outcome.
What made you think that you want to correlate it with the emergence time? Like the POCD,
ma'am, because the hippocampus itself.
Emergence time is something different. There,
Yes,
different factors determining it.
Yes, ma'am. Thank you for the question. The hippocampus itself will predict, it plays a major role while emergence, because initially it is the deep gray matter structures which gets activated in the brainstem, and then it comes over to the hippocampal region and the thalamus, and then to the cortex. So if at all we have any disturbances in the hippocampus or the thalamic region, the patient would not wake up because the emergence would delay, because the signal will be delayed reaching to the cortex.
Okay.
Okay, one more aspect about your technique itself.
Yes, sir.
You said that you reverse a patient once you had a T3 count, and yes, then did allow the patient to breathe spontaneously, or you were continuing ventilation? And what was your endpoint to say that patient has recovered, whether it was patient opening eyes to command or any other thing, whatever you have taken that?
Yes, thank you for the question, sir. So once the top count was greater than 3, we reversed the patient, and then we put the patient on spontaneous ventilation. Okay. Once the patient was put on spontaneous ventilation, we gave an oral command to the patient to open the eyes, as and when without touching the patient. So with the vocal command, without no touch technique, the patient, when he opened the eyes, we took the phase of opening the eyes at that point of time, and the phase of obeying the commands to either like lift your hands, lift your legs, show me your tongue. So those were the oral commands given. Once the patient obeyed those commands, we take those time points as phases of emergence, and the time of extubation at the time when we extubated the patient as time of extubation.
We have to go to the next candidate.
Yeah, okay.
Thank you, sir. Thank you, ma'am.
Dr. Gopalakrishna, I am presenting a comparative study of SCP-based cerebral ischemia monitoring and preemptive anesthetic neuroprotection for neurological outcome in patients undergoing temporary clipping during intracranial aneurysm surgery. The major cause of morbidity and mortality in patients with ruptured intracranial aneurysm treated with neurosurgical clipping is perioperative stroke, and the incidence is around 10 to 12%. Temporal artery occlusion of the parent vessel minimizes the risk of intraoperative rupture and helps in dissection of aneurysm. Prolonged temporary artery occlusion can compromise the distal cerebral perfusion, leading to cerebral ischemia. There are various measures to decrease the risk of focal ischemic injury during temporary arterial occlusion, and one of them is the SCP monitor to monitor the cerebral ischemia and to take a corrective measure based on the changes. Most commonly adapted clinical practice is permissible hypertension with or without pharmacological neuroprotection during temporary artery occlusion. Neuroprotection offered by the pharmacological drugs during aneurysm clipping is unpredictable, and the evidence for same is lacking in the literature. There are no studies available comparing the SCP monitoring versus the use of pharmacological neuroprotection for reducing risk of focal ischemic brain injury during temporary artery occlusion in neurosurgical ruptured aneurysm clipping. This study was done to compare the two techniques of clinical practice and their influence on post-operative stroke and neurological outcome. The primary objective was to find the difference in the incidence of new onset neurological deficit within 24 hours post-operatively between the two groups, and the secondary objective to find the difference of neurological outcome between the groups as measured by the extended Glasgow outcome scale at discharge and at 1 month. This was a prospective randomized comparative pilot study conducted at NIMANS, where 24 participants were randomized into 2 groups, 12 in each group, and study duration was 1 year. This research was funded by ISNACC. After ethical approval and informed consent, patient aged 18 to 65 years requiring temporary parent vessel occlusion during the surgical clipping of ruptured intracranial aneurysm of anterior circulation were included, and patients who had previous stroke or coronary event or patients who had previous intracranial surgery or spinal surgery were excluded for this study. After randomization of 24 patients into 2 groups, each group has 12 patients. In group I, that is SCP-based cerebral ischemia-based monitoring, baseline SCP was done before the temporary clipping. and any significant change in SCCP after the clip application suggesting cerebral ischemia was informed to the surgeon. Simultaneously, appropriate measures were taken like increasing BP or alerting the surgeon for the removal or manipulation of the temporary clip. In group N, that is the neuroprotection group, the propofol is used to give neuroprotection by achieving a burst suppression ratio of more than 50% based on the BIS monitor. A baseline SCCP was taken before the temporary clipping, but after achieving burst suppression and monitored for any significant change. In both the groups, MAP was maintained 10 to 20% above the baseline, and anesthesia induction, maintenance of anesthesia and extubation was standardized in both the groups. Based on the aneurysm location, upper limb SCCP and lower limb SCCP was recorded. Upper limb SCCP was recorded to get N20 complex by stimulating the median nerve, and lower limb SCCP was recorded by stimulating the tibial nerve to get the P40 complex. Significant SCCP change is defined as either a 50% reduction in the amplitude or 10% latency prolongation. The statistical analysis was conducted using a R software. Quantitative data expressed as medians and interquartile range. Qualitative data was expressed as frequencies and percentage. Comparison of qualitative data between the groups were conducted using chi-square test. Interval scale data between the group comparison was done by Mann-Whitney test. P-value less than 0.05 was considered as a level of statistical significance. Coming to the results, demographic profile and including the WMSA grade and duration since test was comparable between the groups. Regarding the hemodynamic variables and vasopressor use, there was no significant difference between the two groups. Aneurysm rupture was seen in one case in group I and 4 patients in group N, which was not statistically significant. Total duration of temporary clipping and maximum single temporary clipping duration was prolonged in group N compared to group I, where the p-value was showing trend towards significance. The new onset neurological deficit was seen in 2 patients in group A and 4 patients in group N, which was not statistically different. The incidence of cerebral vasospasm and delayed cerebral ischemia, there was no significant difference between the two groups. The hospital stay and ICU length of stay, there was no difference between the two groups. Each group, 1 patient died in the hospital. And the Glasgow outcome scale extended at discharge and 1 month, there was no significant difference between the two groups. So out of the 6 cases developing new onset neurological deficit, 3 cases had ischemic changes in SCCP. Out of this, 2 cases had post-op neurological deficit and 1 case did not manifest neurological deficit. Out of 6, 2 cases had no ischemic changes on SCCP but developed neurological deficit, and 1 case no baseline SCCP recording was available. Based on this, the sensitivity of SCCP in detecting the ischemic changes for prediction of neurological deficit was 40%, while specificity was 94% in this study. The literature suggests the diagnostic accuracy of SCCP during intracranial aneurysm clipping for perioperative stroke had a sensitivity of 25 to 50% and specificity of 84% to 95%, which is similar to our study. The maximum single temporary clipping duration and total duration of temporary clip was longer in neuroprotection group compared to the cerebral ischemia monitoring group. This might be because more number of patients had intra-op aneurysm rupture in the neuroprotection group. There was no statistical difference between the two groups for new onset neurological deficit within 24 hours between the groups, and there was no difference in the neurological outcome at discharge and at 1 month. In a study by Mahajan et al., where they used propofol as a neuroprotection during the temporary clipping for the aneurysm surgery, and they showed that it did not offer any advantage as far as the neurological outcome is concerned. The limitation of this study, it's a single center pilot study with small sample size. Only somatosensory tract was monitored. Motor tract was not monitored. So motor evoked potential may improve the accuracy and sensitivity of stroke prediction. Only anterior circulation ruptured aneurysm was studied in this study. To conclude, the sensitivity of SCCP in detecting the ischemic changes for prediction of neurological deficit was 40%, while specificity was 94%. This study shows no difference in risk of focal ischemic brain injury or new neurological deficit between preemptive anesthetic neuroprotection versus SCCP-based cerebral ischemia monitoring alone during temporary arterial occlusion in patients undergoing anterior intracranial ruptured aneurysm surgery. Multicentric randomized studies with large sample size are required to confirm these findings. I'm Dr. Gopalakrishna. I'm presenting a comparative study of SCP based cerebral. Yeah, I'm Dr. Gopalakrishna. Yeah.
Gopalakrishna, you said that you randomized the studies. Did you initially thought that we'll use, you did the randomization right before the induction or only when there is clipping was going on? Or
No, this was done before the starting of surgery, sir.
So you had already knew that if this patient is going to have the rupture, we are going to do this monitoring like that.
It was not depending on the rupture, sir. We just in both the groups, SCP monitoring was done. But one group there was we gave neuroprotection. Other group we just managed with increasing the blood pressure, whatever routine we used to do.
So you said that in the 2 patients with SSC group had ischemia, 3 patients, isn't it?
Yes, sir. 3 patients, yeah.
So what was the, what did you do after that? When you detected ischemia, what was your...
Actually, all the 3, sir, they were actually in the neuroprotection group.
Oh, neuroprotection group.
All the 3. And the temporary clipping time was more than 30 minutes actually in both the groups.
Gopal, don't you presume that it is a foregone conclusion that if you are protecting the vein, naturally the changes will be less. So if I'm already giving a protective measure, then I naturally expect better results, don't I? So does it prove a point?
But there is no studies comparing the neuroprotection versus only ischemia monitoring to see whether there is a beneficial effect of pharmacological neuroprotection.
Yeah, that is basic point actually, whether this neuroprotective measure has any influence on the outcome. That was that is a basic idea, isn't it?
You wanted to prove that monitoring should be done if I am going for a temporary clip. Is it so?
Yes, madam. Yeah, we just wanted to do.
Now that we have that modality at our hand, you feel that it should be done. That is what you want to prove?
But there is no, because larger sample size is required to show the difference, madam. Whatever we have studied is just a pilot study. So to prove it, I think we require larger sample size. We calculated it will come around more than 150 patients.
Yeah. See, one more aspect is that you have monitored SSCP on one group and you have given neuroprotection on the other group, and you have detected ischemia in SSCP group.
Yes, sir.
But you don't know whether there was any ischemia in the other group or not, isn't it?
No, sir. Other group also, after giving burst suppression, we took a baseline SSCP actually.
Okay, that you had not mentioned there. So
actually, there is an ethical concern is there. So in ethical committee, they had asked you have to do in both the groups.
Yes, correct. That's
so
what I
we
thought.
did the same thing in neuroprotection group. After giving burst suppression, we took the baseline SSCP, like amplitude and latency we recorded. And we asked the surgeon to put the temporary clip. From there on, we compared whether before putting the temporary clip, what was the baseline, and we compared thereafter whether there is any change out there.
Did you face any complication for the neuroprotection that you gave? What is the biggest problem that we face? Why don't we just kind of use?
Yeah, man, I got your point. The major problem is it can cause hypotension.
Yeah. So did you measure?
Yeah, most of the time we used to keep the NORAD infusion ready. So in case if there is any, after giving propofol bolus to achieve the burst suppression, then we have to start the vasopressor to keep the blood pressure at least 10 to 20% above the baseline.
So you had to use NORAD in some cases?
Yes, madam. Yeah, definitely. We used actually.
You have to go next candidate.
Yeah.
Okay, thank you, madam. Thank you, sir.
Good evening, everyone. I hereby present a comparison of the effect of anesthesia with sevoflurane and propofol on cerebral oxygenation during hyperventilation in patients undergoing supratentorial tumor excision. The administration of total intravenous anesthesia and transient hyperventilation are common strategies for the reduction of intracranial pressure during supratentorial tumor excision. The Brain Trauma Foundation recommends the use of a cerebral oxygenation monitor while instituting hyperventilation for reduction of ICP. The inhalational agents, which are cerebral vasodilators, and intravenous agents, which are cerebral vasoconstrictors, have variable effects on cerebral blood flow and subsequently on cerebral oxygenation. Propofol, being a cerebral vasoconstrictor, when administered along with hyperventilation, can have deleterious effects on cerebral oxygenation. Based on this, we formulated our hypothesis as cerebral oxygenation is better with sevoflurane than propofol during hyperventilation in patients undergoing supratentorial tumor excision. Our aim was to compare cerebral oxygenation using near-infrared spectroscopy (NIRS) between patients receiving sevoflurane or propofol at normocarbia and during hyperventilation for supratentorial tumor excision. Our study was a prospective single-blinded randomized control study with a total sample size of 50, 25 in each group. After getting institutional ethics committee approval and CTRA registration, we proceeded with patient enrollment. 96 patients were screened, out of which 57 patients were included based on inclusion and exclusion criteria. We randomized the patients into two groups, Group P, TIVA group, and Group S, sevoflurane group. 7 patients who had a difference of 10% or more in the baseline NIRS values between right and left sides were excluded. Finally, data was analyzed in 50 number of patients. When the patients were taken into operation theatre, ASA standard monitors were attached, NIRS and BIS monitoring was started. Then FiO2 of 0.5, the corresponding NIRS value was noted, and this was noted as baseline. Then we proceeded with induction of anesthesia. Group P induced and maintained with Snyder model TCA of propofol, targeted to a BIS value of 45 to 55. Group S induced and maintained with sevoflurane, concentration targeted to a BIS value of 45 to 55. After administering injected fentanyl and vecuronia, trachea was intubated, and we started the patients on volume control mode of ventilation with air oxygen mixture with FiO2 of 0.5, titrated to an EtCO2 of 35 millimeters of mercury. At the end of 15 minutes, an arterial blood gas analysis was done, and PaCO2, EtCO2 gradient was noted, and ventilation was adjusted. When the PaCO2 value reached 36 to 38 millimeters of mercury, the corresponding NIRS value was noted, and this was denoted as the point of normocarbia. Then we hyperventilated the patients for 15 minutes of duration. When the PaCO2 value reached 30 millimeters of mercury, the corresponding NIRS value was noted, and this was denoted as the point of hyperventilation. Our data was analyzed, and continuous variables were expressed as mean and standard deviation, and categorical data as number and percentage. Intergroup analysis was done using unpaired t-test. A p-value of less than 0.05 was significant. From the table, it's clear that both the groups were comparable in terms of demographic and hemodynamic parameters. During hyperventilation, we could attain a target PaCO2 value in both the groups. When we see the diagnosis of cases, 72% in Group P and 68% in Group S were frontal gliomas. When we analyze cerebral oxygenation by NIRS, we could find out that during hyperventilation, there was a statistically significant drop in NIRS value in Group P patients. The lowest and highest values of NIRS in Group P was 52 and 71, and in Group S, it was 52 and 70. Since majority of the cases were frontal gliomas, we did a subgroup analysis in those patients. Interestingly, we could find out that during hyperventilation, there was a statistically significant drop in NIRS values in both P and S groups. So, we proceeded with analysis of tumor side and normal side separately in both the groups. There we could find out that during hyperventilation, there was a statistically significant drop in NIRS value on the normal side in Group P patients. The change in cerebral oxygenation that occurs with varying PaCO2 concentrations give a hint of the integrity of the cerebrovascular reactivity. In our study, in Group P, a significant decrease in NIRS was observed during hyperventilation. 2 patients in Group P and 1 patient in Group S had RSO2 less than 55 during hyperventilation. This effect was marked on the normal side. We assume that this effect was not seen on the tumor side due to impaired cerebrovascular reactivity and abnormal vasculature, which can be seen in patients with intracranial space occupying lesions. TIVA with propofol can cause cerebral vasoconstriction, which can lead to ischemia, more so in patients with raised ICP, especially during hyperventilation. Ours was the first study in neurosurgical patients assessing cerebral oxygenation during the combined effect of anesthetic agents and hyperventilation. Previous studies which demonstrated the decreased RSO2 values with hypocapnia were done in non-neurosurgical elderly patients. Our study pointed out the possibility of the same even in healthy adults. Since NIRS can be applied in frontal region, we have included more of frontal glioma in our study. Our study was not without limitations. We assessed only the RSO2 values, not the cerebral blood flow. We did not address the variation in regional cerebral blood flow reduction between sevoflurane and propofol. Patients with features of raised ICP were not included. Ours was a study of small sample size of 50. It was a single center study. With all this data, I would like to conclude hyperventilation reduced cerebral oxygenation in patients with supratentorial tumors, which were more marked with TIVA. So, a close monitoring for cerebral desaturation is needed in neurosurgical patients when administering hyperventilation for reduction of intracranial pressure, especially when using total intravenous anesthesia. Thank you.
So Shalini, isn't it? So you recommend whether you recommend intravenous or inhalation agents for tumor surgery now with this conclusion?
Good evening, sir. Thank you for the question, sir. And actually,
whether you would like to use sevoflurane or would you like to use propofol or TIVA for cerebral tumors?
For better brain relaxation, we would recommend using TIVA, but from our study, we would recommend the use of a cerebral oxygenation monitor while we are using TIVA and hyperventilating the patient. That was the conclusion of our study.
You have already used cerebral oxygenation and shown that there is a decrease in the oxygenation with in the propofol group, isn't it?
Yes.
So you think that sevoflurane group is doing better than the propofol group?
We found out that there was decrease in cerebral saturation in both the groups. In sevoflurane group also, one patient has desaturated up to 52 in one side, but in TIVA group, while comparing the total number of patients, it was more statistically significant in TIVA group. That was it. In sevoflurane group also there was desaturation, but it was more pronounced statistically in TIVA group.
See, I still haven't understood what you're trying to say. What is your final message to the audience? Like, suppose one doesn't have the monitor, but we are routinely doing these kind of cases are being done with everybody. Both types of techniques are very much there. Hyperventilation is being used to bring down the ICP is because these patients have a tendency for increased ICP. So what is your take-home message? What is your clinical significance? At the end of the day, what is the study about?
While using hyperventilation and administering TIVA, it would be better to use it. NIRS being a non-invasive monitor, we can put in every other case. It's a non-invasive, just like our pulse oximeter, we can use in every other case.
Okay, so you can detect. That is a detection technique. You know, like you used a monitor. So what does it finally do to your clinical management?
Clinical applications.
Yeah, application.
Actually, if it is going into clinically significant level of desaturation, like less than 55, we can limit our hyperventilation, extent of hyperventilation, and ask the surgeon to put an EVD or other measures to control the for better brain relaxation. We can use. There is no per se cutoff for the value of hyperventilation we can give. But general idea we will get from this value. If the trend, if we see, if it is going in for a desaturation.
Okay, madam. Next candidate.
Please, yeah, we'll get late.
Thank you.
Opportunity to present the article in the esteemed ISNACC forum. I'm truly grateful for that. The title of the presentation is Evaluation of Effect of Addition of Ketamine or Dexmedetomidine along with propofol infusion on cranial nerve monitoring in patients undergoing posterior fossa surgery. Anesthesia affect the MEBs, that is the motor evoked potential. In this study, we evaluate the effect of adding ketamine or dexmedetomidine on the amplitude and latency of MEPs of cranial nerves in patients undergoing posterior fossa surgeries. The hypothesis is that the fixed doses of dexmedetomidine will have no effect, and sub-anesthetic dose of ketamine will augment the amplitude and latency of the MEPs. Coming to the materials and methods, this was a prospective randomized double-blind placebo-controlled study. 42 patients aged 18 to 60 years with ASA grade of 1 to 3 undergoing posterior fossa surgery were randomly assigned in 3 groups with sample size of 14 in each group. Group S was the saline group at 0.25 ml per kg per hour. Group D was a dexmedetomidine group at the dose of 0.25 microgram per kilogram per hour. And group K, that is ketamine, at 0.25 milligram per kilogram per hour. Anesthesia was maintained with target control infusion for propofol using Snyder model with an effect site concentration of 2 to 5 microgram per ml and fentanyl of 1 to 2 microgram per kilogram per hour and mixture of air and oxygen. Study drug infusions were started just after induction and muscle relaxants were only used to facilitate endotracheal intubation. Optimal anesthesia depth was achieved to maintain a BIS of 40 to 60. The ETS was established at baseline and maintained throughout the surgery. MEPs were recorded simultaneously from masseter, oculi, mentalis, stylopharyngeus, trapezius, and tongue muscles bilaterally at predetermined intervals. That is T baseline, T2, which was averaged over 60 minutes after induction till the tumor dissection, T3, which was averaged over 120 minutes during the tumor dissection, T4 at hemostasis, and T5 at dural closure. This here shows on the left the electrode placement for the cranial nerve monitoring, and on the right shows a stimulating electrodes placement at the C3 and C4 site according to the 10-20 international system. This is a consort diagram. Coming to the result, the heart rate was significantly higher in group D, that is dexmedetomidine, compared to the other groups. Mean arterial pressure was higher in the group ketamine as compared to the other groups. Emergence reaction was observed solely in 5 out of 6 patients extubated in the group K. Post-operative pain scores were higher in the group saline as compared to the other groups. Here, this shows a trend of muscle amplitudes over time in between the 3 groups. Clearly, the ketamine group shows the higher amplitude as compared to the other groups, and also the ketamine demonstrated maintenance of the amplitudes compared to the baseline throughout the surgery. Coming to the discussion, in our study, there was sustained and reliable MEPs in all the study groups. We observed that the amplitude and latency were largely maintained close to baseline in the group ketamine, whereas the amplitude was decreased and latency was increased in the group S and the group D. The hemodynamic parameters were largely maintained in all the groups. Intergroup analysis demonstrated that the amplitude will remain comparable to each other except in the 7 muscle groups. In these groups, a significant difference was noted in between the group dexmedetomidine and the ketamine versus the group S. Ubag et al. Have documented similar non-significant improvement in the amplitude after a bolus dose of ketamine. Sihel, Vesal et al. In their study have concluded that ketamine diminishes the depressing effect of propofol on the MEPs. We found higher BIS value in the group ketamine. This was similar finding in the Hans et al. Study. There was also reduced requirement of propofol and fentanyl. In our study, there were about 7 patients in group saline developing either a new deficit. This can be because of higher requirement of propofol and fentanyl in this group. The study had following limitation of small sample size, and secondly, use of analgesia, nociception index would have been better to define the opioid sparing effect of study drugs in the post-operative period as well. So to conclude, that the intraoperative infusion of sub-anesthetic doses of ketamine and dexmedetomidine as an adjunct to propofol fentanyl-based TIVA provides a good condition for intraoperative neuromonitoring. These are the references, and thank you so much.
Question answers, please.
Yeah. So you basically think that the SSCP, the amplitude and latency are well maintained with both dexmedetomidine and ketamine. Is that?
Good evening, sir.
Yeah.
Yes, sir. So in this study, we found that the amplitude and the latency changes were were comparable in the ketamine group compared to the baseline, better than dexmedetomidine.
So there is no change with
the
ketamine, almost no changes. That's what you feel.
Yes, sir. So basically, yes, sir.
Between dexmedetomidine and ketamine, what was the influence?
Sir, in this, between comparing the ketamine and the dexmedetomidine, only we found that the changes were comparable to the baseline. So
now, between these two groups, did you find any change, or they were very similar? That's all I just saw. Between
no, sir, there was change. Yes, there was significant change.
Significant
between
change
the dexmedetomidine and the ketamine group.
It was statistically significant?
Yes, sir.
So
The statistic, it was, sorry, sir, that slide
that should have mentioned as one of the outcomes also, isn't it?
Why is it not reflecting in your conclusion?
Yeah, that's right. That's what I was.
Yes. I hope you're not getting confused, because somewhere you said that they are both good drugs, which means that you're able to do your MEP recordings when you're adding either of them to the baseline anesthesia. But if one is superior to the other, first of all, foremost, what was your hypothesis? Were you thinking one is superior to the other, or non-inferior to the other, or what do you think was the what was your hypothesis?
So the hypothesis, ma'am, the hypothesis was that the both the dexmedetomidine and the ketamine doses will have a better effect on the amplitude latency.
Comparing, no, you cannot have both drugs doing better. Are you comparing the two regimes? What are you doing? I'm still.
So, ma'am, that's what we hypothesized that the fixed doses of both the ketamine and the dexmedetomidine will augment the amplitude and the latency of the corticobulbar MEPs.
So you could have studied just why you bringing in two drugs. If you bring in two drugs to a basic anesthesia regime, that means you have something in mind that you want to compare and give results, right? You want to compare, you're bringing in two drugs, and then you've done the whole study with two drugs. So in the end, you'll come with some kind of conclusion that this is a better drug, or this is not better, or maybe both were same. So that is not reflecting in the conclusion. You started out they will not affect the MEPs.
Exactly. The advantages of dex and the disadvantages of ketamine are universally known. So
yes, ma'am.
I agree with Pragati. What is the point in comparing the two?
Ma'am, the point was that like, for example, when because most of the posterior fossa surgeries go on for a long period, so there is anesthetic fade. So we can use ketamine, because with this study we have proven that the amplitudes with a sub-anesthetic dose of ketamine gets improved. So it is better to use ketamine. Ketamine will have a better effect on it.
But then you're not ending
as compared to dexmedetomidine and the saline group. That is what we found in the study.
So basically, you compared saline with other two groups of that, but between dexmedetomidine and ketamine, you didn't actually give your results for that one, but you just compared it blind. That is one aspect of it. You said there were neurological deficits in patients who had received saline.
Yes, sir.
So what was the significance of that? I don't know. Whereas it was not there in the other group. That's what you said, mentioned, isn't it? If I'm...
Yes, sir. So that was because basically in the saline group there was higher requirement of propofol and fentanyl in these in this
But
group.
you maintained
Yes,
all these patients in the same BIS monitor, BIS level, isn't it?
yes, sir, 40 to 60.
So you
Yes,
require
sir.
more
So
than
probably that
propofol.
confounded the effect of surgery on the intraoperative MEP recordings.
We have to move to the next candidate.
Hello.
Okay.
I think we still have a long list here.
Yeah, we'll go on to the next paper.
Thank you.
Everybody, my name is Gautham. I am currently working as a clinical fellow at the Department of Neuroanesthesia at the National Hospital for Neurology and Neurosurgery, Queen Square, London. My presentation today will be an audit on post-operative delirium in neurosurgical patients at our hospital. Most of us are well aware of the adverse effects of post-operative delirium on things like hospital stay, recovery, outcomes, etc. But what may not be very well understood is that it has very significant economic effects too. Some studies done in Canada and the US have shown that the annual costs attributable to post-operative delirium is about $33 billion every year, which is about nearly the entire healthcare budget of India in the year 2019. Therefore, efforts to prevent post-operative delirium can have significant economic benefits as well, in addition to improving outcomes. Recently published guidelines have emphasized that identifying risk factors for post-operative delirium during pre-anesthetic evaluation is a practice which has a very high potential for impact in reducing post-operative delirium. Therefore, we have undertaken a quality improvement project in our hospital in collaboration with the neurosurgeons, the nurses, and neurocare of the elderly. As a part of this project, we conducted an audit to find out how common post-operative delirium was. We also wanted to identify risk factors associated with post-operative delirium, and finally to study compliance with published guidelines for prevention and management of post-operative delirium. The next few slides, I'll talk about our study protocol, the data we collected, and our results. So our study was a retrospective study where we reviewed the electronic health records system of consecutive patients undergoing elective and non-elective neurosurgical procedure over a 2-week period. The data we collected included demographics, the type and site of surgery, risk factors like ASA grade, clinical frailty score, comorbidities, personal habits, pre-existing neurological and mental health disease. We also looked at post-operative complications like infections, electrolyte imbalances, ICU admissions, dehydration, length of hospital stay. We reviewed the records to see how many of our patients had a baseline cognitive assessment preoperatively and how many were screened for delirium postoperatively. We also looked for delirium by performing a keyword search. We used 5 keywords to search patients' notes. These were delirium, disorientation, drowsiness, confusion, and agitation. Coming to our results, our study included a total of 114 patients who were equally distributed among the 2 genders and equally distributed among elective and non-elective surgeries. About 48% of our patients were ASA grade 3 and above, and about 17% of our patients had a clinical frailty score above 4. In terms of our main findings, we found that about 27% of our patients developed delirium postoperatively, which is fairly consistent with what is described in literature. We also found that the average hospital stay was significantly higher in the delirium group, with a median of 11 days as compared to 4 in the non-delirium group. Now, coming to the risk factors for postoperative delirium, we found that patients with ASA grade 3 and above, the incidence of delirium was significantly higher than it was in patients with ASA grade less than 3. Similarly, patients with a clinical frailty score above 4 had a significantly higher incidence of delirium as compared to patients who had clinical frailty less than 4. And further, in patients who were admitted to ICU postoperatively, the incidence of delirium was nearly 50%, and that was significantly higher than patients who were not admitted to ICU. And finally, Among patients who had developed dehydration post-operatively, almost 90% developed delirium, which was significantly higher than non-dehydrated patients. We did not find any significant association between gender, the urgency or site of surgery, and the incidence of delirium. Also, none of our patients had a baseline cognitive evaluation preoperatively or a screening for delirium postoperatively. Now, to summarize our findings, we found that postoperative delirium was fairly common among our patients. And also the risk factors, as I've already described, with an increased incidence of delirium can be identified very easily by performing a screening during pre-anesthetic evaluation. Also, we found that the adherence to post-operative delirium guidelines was low. Now, as a part of our quality improvement project, we planned interventions which were in keeping with published guidelines. So we planned interventions in 2 phases. So phase 1 included interventions which could be implemented in a relatively short time frame. We have actually completed most of these so far. So these included educating the nurses in the pre-anesthetic clinics about the importance of documenting baseline cognitive assessment and clinical frailty score. We also tried to make documentation of a delirium risk assessment scoring easier by developing a smart phrase on our electronic healthcare system. We also developed similar smart phrases to paste mnemonics into our anesthetic handovers, which would then help the nurses and the neurosurgical personnel identify and treat causes for delirium postoperatively. And then phase 2 included more long-term interventions which required collaborating with other departments. And here we planned to conduct regular presentations to our anesthetic colleagues, highlighting the importance of adhering to guidelines. We also circulated educational materials, infographics at frequent intervals to emphasize this point. We also aimed to conduct educational sessions for the nurses and neurosurgeons with an aim to increase awareness among them about postoperative delirium. And finally, we also aimed to conduct cycles of pre-audits in order to monitor the effectiveness of the implementations we were making. And in fact, we have concluded one such audit where we found that the incidence of our patients having 480 assessment and clinical frailty documented in their pre-anesthetic evaluation has gone up from 0 earlier to about 40%. So that would suggest that we are on the right track. I would like to thank everybody for patiently listening to my talk, and I would be happy to welcome questions at this point. Thank you very much.
Good morning, everybody.
Dr. Gautham, in your study, of course, you have mentioned that you had not done any evaluation pre-operatively, but you had post-operatively some 27% of the patient had cognitive dysfunctions. So this is one aspect. Unless you have pre-operative assessment, it will be difficult to come to some conclusion on this basis. Secondly, in the group of those who developed cognitive dysfunction, that is some 27%, how many people were aged? Actually, you have not shown the age-wise distribution because that is a very significant factor in developing cognitive dysfunction post-operatively.
Yes, sir, that's absolutely correct. Actually, we have not analyzed the distribution of delirium in terms of age. This study we started this study with keeping in mind basically how our anesthetic practice was happening in terms of adherence to what guidelines we had. So that's the assessment in terms of age is something we actually missed. Probably in the subsequent audits that we will do, we'll likely look at this aspect. Definitely, we're not analyzed in terms of age. That's something we have not done in this study.
Dr. Gautham, I'm really surprised at the incidence of delirium that you are quoting, and I'm very sure Dr. Parameshwar will also agree with me, and Pragati will also agree with me that I'm very, very sure that our rate is not so high. Maybe you have a higher age, just like Dr. Parmeshwar was saying, that the age group, the higher age group, may be more in your series. Because it's an alarming rate of delirium, isn't it so, Parmeshwar?
Yeah, exactly. That's why I was wanted to know what is the age group distribution there.
So actually, sir and ma'am, the incidence
It's
that is
almost
quoted in
every
literature.
second person in your series is having a delirium after recovery. And we are very surprised at that.
Yeah, actually, across the world, if you look at all the studies that have been done on post-operative delirium all over the world, what is quoted in literature is it varies from 10% to up to even 65%. But what is the most commonly quoted figure is around 30%. That is what is that is the established figure all over the world in literature. And I am sure I worked all my life, and it's only for the past 1 year that I've worked here. And I have, in my experience, I have not, I've felt that the incidence of delirium is probably not, it's not as less as we think it is. It's probably that we tend to miss out on a lot of these things because I don't, I, I think we are missing a lot of data. I'm pretty sure that the incidence of delirium in our patient population is much higher than we think it is.
And one more aspect which would be interesting, though you have not compared, is between those who underwent cranial surgery and those who underwent spinal surgeries. Whether that would make any difference or not, we don't know. But
we don't.
That is another aspect which you can see.
That is true. Should make some difference. Yes. Okay, I think next Indranil will shift.
Yeah, next speaker.
On to the please next one.
Good evening. My topic is efficacy of near-infrared spectroscopy to predict perioperative complications in patients presenting for surgical excision of cerebral arteriovenous malformation. Cerebral AVMs present a low resistance circulation, which renders the perineal tissues susceptible to ischemia. But post-excision, there is an increased flow to the surrounding perineal tissues, resulting in hyperemic complications. Also, therapeutic-induced hypotension and cerebral edema post-op can result in ischemic complications as well. Hence, the crux of perioperative management is to achieve a balance between optimal cerebral oxygenation and prevention of cerebral hyperemia at the same time. NIRS helps to detect cerebral ischemia or hyperemia by measuring the regional cerebral oxygen saturation. While RSO2 cutoff values of 12% have been described for procedures like carotid endarterectomy, there is paucity of literature on the use of NIRS in AVM surgeries, hence the relevance of our study. Our hypothesis was that the use of NIRS helps to detect changes in cerebral oxygenation and helps to predict perioperative complications in patients for surgical excision of AVM. Primary objective was to study the correlation between periprocedural changes in RSO2 and perioperative neurological complications. Secondary objective was to determine an NIRS threshold value to indicate cerebral ischemia or hyperemia in AVM patients. Our methodology, this was a prospective observational study where 20 patients were initially screened. After applying the inclusion criteria and exclusion criteria, 6 were excluded and 14 were included and finally analyzed. All standard ASA monitors were applied and NIRS sensors were placed bilaterally. N1 was the baseline NIRS before induction. Anesthesia induction and inhalational maintenance was standardized for all patients. NIRS recordings were taken at various time points such as N2, that is 10 minutes after induction, N3 after arterial ligation, and N4 after venous ligation, N5 after resection of the AVM, N6 was the first value post-op in the ICU, N7 to 17 was hourly in the ICU, and NC was a recording at the time of complication. Blood pressure was maintained at baseline throughout surgery. Post-excision blood pressure maintained at baseline or 20% of baseline using SMP infusion or according to the NIRS recordings. A significant drift was defined as a drift of more than 12% RSO2. If such a significant drift was noted, the following interventions would be performed. That is, inform the surgeon or the intensivist, inspect the operative site,
optimize anesthesia, optimize FiO2, hemoglobin and blood pressure, and a tight blood pressure control with SNP or an urgent CT would be ordered. Our results were as follows. 35.7% of the patients were in the age group of 16 to 20 years. 78.6% of the patients were males. 50% of the AVMs were SM grade 2, 28.5 was SM grade 1, and 21.4 was SM grade 3. Most of the AVMs were located in the parietal location, followed by the frontal, followed by frontotemporal and insular and temporal. One patient had hypertension, another diabetes, both were well controlled. We observed that in group B, that is the group where the patients developed complications, there was a significant drift in the RSO2 values post-excision. As you can see, at time point N5, that is at this point, there was a significant drift in the RSO2 value. At this point, we intervened to control the blood pressure more tightly so that to avoid hyperemia. Following that, the RSO2 values decreased. However, at time point NC, that is at this time point when the complication occurred, we noticed there was a significant negative drift in the RSO2 value. Hence, we optimized our blood pressure management so as to avoid excessive hypotension. And after that, RSO2 values improved. We observed that 21.4% of the patients had a significant drift in RSO2 of more than 12%. Among them, there was a 100% incidence of post-operative complications. While 78.4% of the patients had an RSO2 drift of less than 12%, 18% of them had post-operative complications. This signifies that those who had a significant drift of more than 12 had a 100% incidence of post-op complication. Coming to post-op complications per se, highest incidence was noted for generalized seizures, followed by delayed extubation and re-intubation, and one patient each had EDH, focal seizures, cerebral edema post-op, and venous infarct. We observed that 40% of the patients who developed complications had SM grade 2 and 60% who had complications had SM grade 3. In our study, the incidence of hyperemia was 7% as compared to 8 to 21% reported by Chui et al. This low incidence in our study could be attributed to the tight blood pressure control, which guided by NIRS monitoring aided us in identifying the critical BP target in each patient, so that we were able to strike a balance between optimizing the cerebral oxygenation and preventing hyperemia at the same time. Also, a significant drift of more than 12% in RSO2 value in our patients want our clinicians to intervene promptly and control the blood pressure more effectively and appropriately. The incidence of seizures in our study population was 28.5%, which was comparable to the findings by Englot et al., who reported an incidence of 12 to 57% after AVM resection. Higher incidence of seizures have also been reported, wherein there was incomplete AVM obliteration and AVMs with deep perforators. In our study, of the 5 patients who had seizures, 2 had residual AVMs post-op and 3 had SM grade 3 with deep perforators. Our limitations was this is a single center study. Other modalities of cerebral oxygenation monitoring were not used and posterior circulation AVMs were excluded. Hence, I would like to conclude by saying non-invasive monitors like NIRS can help to detect changes in regional cerebral oxygenation. A post-operative drift of RSO2 of more than 12% in our study was strongly associated with post-operative complications. Hence, a tight control of blood pressure with a threshold RSO2 drift of less than 12% would help to reduce the incidence of perioperative complications and lead to better outcomes in patients. Thank you. These are my references.
I just wanted to ask you, your cerebral oxygen. Yeah. Between that and the post-op complications, is there a, clinically, if you look at the patient, I mean, if you look at the complication, is there a correlation, like correlation in the sense, do you think there is any relationship between the kind of complications that you've, mentioned here and a dip in cerebral oxygenation, like seizures and other stuff like the complications? So how do you correlate this?
The thing is, we did notice a higher incidence of seizures, but we are not sure.
The other complication, everything, all of them.
Yes, ma'am. The thing is, we cannot exactly, but all these patients who had complications, most of them at least, 3 of them especially, had a significant drift was there. That too, the drift was more on the negative side for the patients. So it could be because of that, but in the other patients, that is majority of the patients, we were able to optimize the BP and avoid the complication. But especially the hyperemic complications. The highest incidence was for seizures. That could have been due to multiple factors. like patients who had pre-op seizures, whose SM grade was higher, then two of them had, it was not completely obliterated. Post-op DSA showed that there was residual AVM. But we also noted that around that time of complication, there was a significant drift in the RSO2 value. So at that time, what we did was to optimize the BP management so that the NIRS values was indicating us that there is probably a cerebral ischemia, or so much of a tight hypotension was not required. So we optimized our BP management accordingly. That's how we did for all the patients, but 5 of them had complications, but not necessarily that it was because of the cerebral ischemia per se, because there were other factors also that contributed to it. But we were able to avoid the hyperemia in majority.
How did you get at this value of 12% as a change?
Sir,
why did, yeah.
So it was based on previous literature studies in carotid endarterectomy, because carotid endarterectomy also, like AVM, it's a hyperperfusion. After the excision, there is a hyperperfusion picture. Pre-op, it's ischemia, and post-excision or obliteration, we expect hyperperfusion. So based on that study, carotid endarterectomy, like our this thing, sir, it was showing 12% in that literature. So based on that, we took a 12% value based on the literature. And we took CEA because of that particular reason. We felt that pathophysiological hemodynamic changes could be similar to AVM, what happens pre and post excision.
Okay.
Move to the next, I think.
Yeah, we'll go to the next.
Today's topic is a prospective observational single center study evaluating emergence agitation in the early post-operative period in adult patients undergoing elective craniotomies under general anesthesia. Emergence agitation is a common complication in early phase of recovery from GA. It can range from agitation, confusion, delirium, or violent behavior. It occurs in the operating room or in the post-anesthesia care unit within 24 to 72 hours after surgery, while post-operative cognitive dysfunction is measured at weeks to months after anesthesia. Patients after craniotomy are more susceptible to stress resulting from emergence agitation during recovery from anesthesia. Increased sympathetic activity may cause intracranial hemorrhage and brain edema. Elevated oxygen consumption disrupts the oxygen demand supply balance and may result in cerebral ischemia. The reported incidence varies from 3 to 21% in adult patients undergoing various surgeries. After approval of the Institutional Review Board and written informed consent from patients, a prospective observational cohort study was concluded on 317 adult patients undergoing elective craniotomy for brain tumor under GA. Study is registered with Clinical Trial Registry of India. Data was collected from 317 consecutive patients undergoing craniotomies under GA in PD Individual Hospital and MRC from April 2019 to March 2020. Inclusion criteria include consenting adult patients between age 18 to 80 years and ASA grade 1 to 3. Excision criteria were pre-operative documented impairment of consciousness, unarousable state during first 24 hours after surgery, re-intubation within 24 hours after surgery, post-operative GCS less than 8, and patients on antipsychotic drug. All patients underwent a thorough pre-operative anesthesia assessment. Data collected pre-operatively were demographic characteristics. In addition, we documented the use of pre-operative anticonvulsant and diagnosis and location of lesion. In OR, the GCS were noted. Standard anesthesia monitoring were supplemented by BIS and neuromuscular blockade monitoring. Invasive arterial pressure monitoring and CVP monitoring was done as indicated. After adequate pre-oxygenation, GA was induced with intravenous fentanyl 2 microgram per kg, propofol 2 mg per kg, atracurium 0.5 mg per kg IV, and airway was secured with an endotracheal tube. Balance anesthesia was maintained with a combined administration of sevoflurane MAC less than or equal to 1 and propofol instead of 100 to 200 microgram per kg per minute. To maintain BIS between 40 to 60, atracurium was titrated to maintain TOF less than 2. At the end of surgery, the patient was used with standard doses of glycopyrrolate and neostigmine. Immediate post-op GCS and visual analog scale were noted. Level of agitation was evaluated in first hour, second, third, fourth, fifth, 6, 8, 12, and 24 hours after surgery by Riker agitation sedation scale. Agitation are defined as score of 5 to 7. 7 is dangerous agitation, 6 is very agitated, 5 is agitated, 4 is calm and cooperative, 3 is sedated, 2 is very sedated, and 1 is unarousable. Intraoperatively, the approach for craniotomy, duration, blood loss, and anesthesia technique were recorded. Serum sodium, glucose, and potassium were also recorded every 2 hours. Post-op, we recorded GCS, Riker agitation sedation score, visual analog pain score, and all complications and use of analgesics were noted. Statistical analysis were performed using SPSS software version 26. Cycles test was applied to test for statistical differences in categorical variables, and student t-test was applied to test for significant differences in continuous variable. P-value less than 0.05 was considered statistically significant. We got the incidence of 5.4% with 17 patients in agitation. Age distribution is not significantly different. Mean duration of surgery did not differ in two groups significantly. However, proportion of patients who had duration of surgery more than 4 hours was significantly higher in agitated group. This can be coincidental because all neurosurgeries are generally more than 4 hours. Imperative blood loss, patient positioning, pre-operative electrolyte and blood glucose levels, and are not statistically significant difference in two groups. In our study, 5.4% patients had an episode of agitation in first 2 hours after post-operative period. Among those agitated, 100% are graded as mild and none required analgesic or sedative. In 2015, Rim et al. And Chen et al. In their studies of adult patients after undergoing GA concluded that male gender could be an independent predictor. The distribution of gender in our study and was not statistically differences. The distribution of patients from two groups was also statistically not significant. There was also no difference in the mean age of patients in two groups. Some earlier studies found the incidence of EA significantly higher in older group. Ratake, etc. classified three age group 18 to 39, 40 to 64 and more than 65 and showed that the younger and older patients were at higher risk for emergence agitation compared to middle age. Function of frontal lobe involves cognition, emotional behavior. Therefore, damage during frontal approach for craniotomy could result in abnormal behavior. Our study did not find any increase in the incidence. In fact, none of the patients with frontal lobe tumor included in our study had emergence agitation. Mean intraoperative blood loss did not differ significantly in agitated and non-agitated group. In 2019, Makaram etc. associated showed intraoperative blood loss with increased post-op agitation. Ratake etc. found longer duration of anesthesia was a risk factor for post-operative emergence agitation. Ramrif etc. also concluded that the longer duration of surgery and anesthesia was a predictor for emergence agitation. Several randomized controlled trials measured agitation with the use of inhalation anesthetic agents and propofol in non-neurosurgical patients and found that propofol might decrease the incidence. In multicentric trial in Europe, emergence agitation was compared among three different anesthesia maintaining methods: sevoflurane, remifentanil, sevoflurane, fentanyl, and propofol remifentanil. No significant difference in agitation were noted among these three groups. However, incidence of agitation reported in our study, 3.7 to 6.5%, were much lower than those in our study. We used both propofol and sevoflurane for maintenance of anesthesia. Limitations of the study: preoperatively psychological testing for depression and cognitive impairment using various scales and objective tests for fatality testing, which may help to identify risk factor, as suggested by ongoing research, were not available or implemented in our study. As our patients was for evaluation, any additional cost for further referrals and testing were a consent in our institution. Specific history of substance abuse or addictions was not obtained from the patients unless volunteered, and being a risk factor, it could have been assisted in identifying patients at risk. Our study got accepted for the publication, and this is the preprint. In conclusion, early objective assessment of these factors of the pre-operative period with objective validated tests and shorter duration of surgery may be the way forward in patients at high risk for emergence agitation to reduce the incidence and mitigate the underlying consequences. These are my references. Thank you.
Ninad, can you just summarize because you went so fast? Can you summarize?
Yes.
Can you conclude?
Yes, ma'am. The incidence we got is around 5.4%, and we got the main factor is the duration of surgery, more than 4 hours. But it may be coincidental because all neurosurgeries are generally more than 4 hours. In literature, they have mentioned that the blood loss more than 500 ml, male gender, use of sevoflurane, and frontal approach or any frontal tumor can also be the cause for the emergence agitation. But in our study, we have not got that. We got the incidence of 5.4%, and all were mild emergence agitation. There was no requirement of any treatment for that.
Okay.
Achha, in balanced anesthesia, if your proportion of anesthesia, analgesia, and sedation and muscle relaxation is adequate, do the judges feel that agitation should be as much as it's being quoted?
It may, ma'am.
Did you compare the incidence between the two, this one, inhalation agents and the intravenous agents? That is,
in our study, we have not measured that, sir, differently.
So you made a whole group and then had an incidence of
Yes.
about 5% approximately.
Yes.
course, which is definitely less than what the other candidate had reported of 24%.
Yes.
Yes. You said the duration of 4 hours. Yes.
Yes.
Do you think anything less than 4 hours would be less, or how is it?
Sir,
because if we have come to a conclusion that the duration is responsible for that, you should have different durations and then say that
yes,
the
sir.
incidence is more in this group, that group, and all that.
Yes, in literature they have mentioned that duration more than,
literature, forget about that. In your study, what was the thing? Because we are discussing your study.
Yes, sir. According to our study, we got more than 4 hours is the risk factor. So less than 4 hours, all neurosurgeries are generally more than 4 hours. So I may have got that results if the duration was less.
Okay.
Pragati, you have any comment on this?
No, ma'am.
No.
Is
Okay, we will
your
go for the next speaker.
agitation rate also as high as this?
Ma'am, yes, it's the same, ma'am. 5.2% I only got, not more than this.
5.2%.
Yeah.
So you went so fast that your figures we missed.
Yeah.
If it's 5.2%, then of course it's perfectly right. Thank you.
Respected teachers and dear colleagues, my study is effect of ketamine infusion as neuroprotective agent or neurological outcome in patients with severe traumatic brain injury, a randomized controlled pilot study. Just going by the background that severe traumatic brain injury is a major cause of disability and morbidity among patients. The preventable part is the secondary brain injury rather than the primary brain injury, and the goal is to prevent or minimize any secondary neurological injury. So sedating these patients becomes a challenge because of pain, anxiety, agitation, and patient and ventilator asynchrony. Therefore, the search for the best analgosedative drug remains a race. The ideal analgosedative drug in such patients should reduce cerebral metabolism, prevent rise in ICP, maintain cerebral perfusion pressure, have anti-epileptic and neuroprotective properties. So several drugs have been studied, but with inconclusive outcome. So coming to the drug ketamine, which has good, excellent analgesic and sympathomimetic properties, it can be used as a sedation also. But since in the year 1964 to 1972, it fell out of favor because of several neurosurgical patients having catastrophic rise in ICP because it was used in spontaneously breathing patients with abnormal CSF pathways who are planned for procedures. But later on, several newer studies and systematic reviews have shown that ketamine possesses neuroprotective potential because of the NMD antagonism. It decreases excitotoxicity, prevents cortical spreading depolarizations and oxidative stress. Hence, this has led to a renewed interest in ketamine as an analgosedative drug. So the primary objective of my study was to study the effect of ketamine infusion as an analgosedation on neurological outcome in severe traumatic brain injury patients. The secondary outcome was to check its effects on systemic and intracranial dynamics. So 60 patients, after obtaining written and informed consent, 60 severe from the relatives, 60 adult patients with severe traumatic brain injury were recruited, which with having ICP monitoring probe in situ. Those who had life-threatening injuries, polytrauma, and with absent brainstem reflexes were excluded from the study. In the materials and methods, the general management in the ICU was done. They were mechanically ventilated. A standard sedation of fentanyl 1 mics per kg and midazolam 0.05 mg per kg per hour were given by continuous infusion as per our institutional protocol. The systolic blood pressure was maintained more than 110 millimeter of mercury, and the study population was between 18 to 49 years. So according to the BTF guidelines, 2017, the SBP was maintained more than 110. isotonic fluid, cerebral decongestants, antiepileptics, vasopressors were all standardized, and normocapnia, normotension, normothermia, normoglycemia were maintained. They were divided into two study groups, the ketamine group and the control group. Randomization was done, and blinding was done by a sealed envelope. The ketamine dose for infusion, the test drug was 50 mics per kg per minute. At the start of the infusion, the test drug was given as 20% as bolus to maintain the blood levels, and both saline and the test drug was then given at the rate of 0.1 ml per kg per hour. And the clinician who was recording the parameters were blinded to the group allocation. So the parameters that were recorded was the baseline GCS, the force code, the motor deficits, the heart rate, the oxygen saturation, systolic, diastolic blood pressures, MAP, ICP, CPP, temperature. Even the ABG and the jugular venous oxygen saturation were recorded 12 hourly. Any episode of ICP rise more than 22 millimeter of mercury and SBP fall less than 110 were recorded. And rest, all the standard care was followed. The neurological outcome was calculated by Glasgow outcome score, extended at 3 months after injury. Appropriate statistical methods were applied. Now coming to the results, the most commonly it was the road traffic accidents, followed by fall and the assault. And the most common type of injuries were subdural hematoma, followed by contusions, diffuse axonal injury, EDH, and traumatic SAH. The variability of the test drug infusion was there between 14 to 36 hours. There was wide variability between the test drug infusion, primarily because these patients were taken for decompressive craniectomy and the ICP monitor was out. In any case, the ICP was more than 22 millimeters of mercury. Now coming with the other results, as we can see in this chart, overall till 2 to 4 hours, the ketamine had a significant rise. There was significant rise in the mean arterial pressure, SBP, and diastolic in the ketamine group. But after 6 hours, the infusions were all same. The systemic hemodynamics was same in both the groups. Even the use of vasopressors was significantly more in the control group. And epochs of ICP rise of more than 22 millimeter of mercury was more in the control group and less in the ketamine group. But after 6 hours, the overall ICP in both the groups were same. Coming to the complications, the number of various complications were in both the groups were statistically, there was no statistical significance. Coming to the outcome score, here we can see in the more number of good neurological recovery by Gaussy grade 7 and 8 were more in the ketamine group. But overall, if we consider Gaussy grade 5 to 8 as good favorable outcome, it was in the saline group. Overall, there was no statistical difference in between in outcome in between the groups. Now, very few studies have been done which compared ketamine as an analgesic sedation in severe traumatic brain injury patients. There were 2 studies which used the bolus, the Albanese et al. And the Dengler, whereas there was 5 studies which have used the infusion. Our study was also not different from others because in our study there was a non-sustained increase, non-sustained maintenance of systemic hemodynamics after 6 hours. Probably there are 2 reasons for that. One possible explanation was the start of vasopressors in the control group. Another cited literature is that in presence of circulating catecholamines, the effect of ketamine is maintained. But in brain injury patients, due to depletion of circulating catecholamines, there was probably a non-sustained effect on systemic hemodynamics. Similarly, only one study has shown has shown the decrease in ICP, that is by Albanese et al. But in all these studies, the results were ambiguous because in later part, after 10 to 30 minutes, there was again a rise in ICP. Similarly, in our study, the ICP was lower in the ketamine group in the initial 2 to 4 hours, but after that, it was statistically significant. Coming to the outcome, only one study per se has shown an improved outcome with ketamine, but no other studies till date has shown an improved outcome with ketamine. And in our study also, the GOSI did not show any difference at 3 months. The limitations of our study was that it was a small preliminary study and a single dose of ketamine, which is given for a short duration of time, was studied. There was no objective measurement of the sedation level, and also we did not measure the level of circulating catecholamines. In conclusion, I would like to say probably further studies are warranted with higher doses and probably longer duration of time. In literature, doses starting from 10 mics to 100 mics per kg per minute has been used. And it is generally seen that in studies like Albanese et al., a higher dose was associated with a better outcome. So further randomized large control trials are needed. Till then, the race for elusive analgosedation in severe traumatic brain injury patient is still on. Thank you, sir. Thank you.
Questions, please.
What was the dose of ketamine used in your study?
My study, sir, the dose of ketamine as an infusion of 50 mics per kg per minute, sir. It was
mics per kg per minute.
Yes, sir. It was given as an infusion, continuous infusion, sir.
Okay. 0.25. It's less actually, is it?
Yes, sir. Actually, in literature, there were 7 studies that we found with infusion. They have started from as low as 10 mics per kg per minute and went up to 100 mics per kg per minute. There are 2 studies, Kariokato et al. And the study that I quoted with another study, which showed that there is improved outcome with higher doses. But in all these studies, there was no conclusive reference on the outcome at 6 months or 3 months.
What is the message from your study? Like,
Sir, madam, the message from my study is that I have done with 60 patients. Rest all the studies till now has done 30 to 40, minimum till maximum 30 patients have been studied. We could probably with higher doses, we went ahead with a moderate dose, probably with higher doses of ketamine. And if we could have studied for a longer duration of time, we could have an effect on the outcome. In our institution, what happened was, in those patients, we had ICP monitoring already going on in these patients. Any patient who had epoch of ICP more than 22 millimeter of mercury for at least 5 minutes or more were considered for decompressive craniectomy. So as soon as the decompressive craniectomy are done, the ICP was removed. Okay. So basically, sir, we did not was not able to find out the sustained effect of this drug on these patients.
So in the ketamine, you had 2 groups. A ketamine group, you said that there are how many patients were taken for decompressive craniotomy in ketamine group and in the other group? Which was more?
Sir, that is definitely a limitation of my study. I have not measured it, but there was.
You should look into that, I think, basically.
Yes, sir.
That's one aspect of.
Yes, sir. I did not calculate those patients. We did not take in it.
Thank you.
Do you mean to correlate the incidence of craniectomy decompressive with the dosage and the type of drug? Was that your intention?
Actually, madam, like sir's question was again, my 2 objective was to study first the effect of ketamine on the neurological outcome, and second, its effect on systemic and intracranial dynamics. There was no objective which there was correlation between number of patients given ketamine or test drug and incidence of decompressive craniectomy. This I did not include in my initial hypothesis.
Right.
We'll have to move to the next speaker.
Yeah, we'll move to the next page.
Thank you, sir.
Charoo Negi.
From Fortis Memorial Research Institute, Gurgaon. I'm Dr. Charoo Negi. I'll be presenting our study, Anesthetic Techniques and Infection Biomarkers, a comparative evaluation of 2 anesthetic techniques during supratentorial craniotomy It's a preliminary study. Surgical site infections following craniotomy is a formidable challenge. Infections after craniotomy warrant prolonged antibiotic treatments and at times additional surgical interventions for successful eradication. This frequently results in significant morbidity, prolonged hospitalization, and increased healthcare expenses. The economic burden of post-operative infections is astounding. Anesthesia and surgery both modulate complex immune responses in patients undergoing major surgery. In our body, there exists a delicate balance between the pro-inflammatory cytokines such as interleukin-6, interleukin-8, tumor necrosis factor alpha, and anti-inflammatory cytokines such as interleukin-4, interleukin-10, and tumor growth factor beta. Cell-mediated immune balance is affected by anesthetics and surgery, and this could increase post-operative infections. Incidence of SSI after neurosurgery is reported to be in range of 1 to 11. In abdominal surgeries, the impact of various anesthetic agents on immunity and inflammatory biomarkers has been studied. However, literature search did not reveal any randomized controlled trial on infection biomarkers following supratentorial craniotomies. We hypothesized that the anesthetic agents modify immune response of patients undergoing surgery, which may affect the incidence of surgical site infection and can be predicted with help of biomarkers. Our primary objective was to assess changes in the infection biomarkers of SSI following supratentorial craniotomies and to find if there was any temporal association between increase in the level of biomarkers with surgical site infection. Our secondary objective was to study the duration of ICU and hospital stay. After obtaining ethics committee approval at our center, we formed a prospective randomized study in which 40 ASA 1 and 2 grade patients were enrolled. Written and informed consent were obtained from all the patients. The patients were divided into two groups, Group S and Group B. Before induction of surgery, blood sample was collected for baseline values of total leukocyte count and procalcitonin. Afterwards, as per their groups, the patients were given balanced general anesthesia. Induction was done with standard technique, including propofol, fentanyl, and rocuronium. Maintenance was done with oxygen, air, and sevoflurane in case of Group S, and propofol in case of Group P. Rocuronium and opioid was repeated as per study protocol. IV fluid administration and blood transfusion was also according to our study protocol. After 12 hours of surgery, a second blood sample was collected for TLC and procalcitonin value. Surgical site was examined every day till patients were discharged and also at the time of stitch removal by the surgeon who was blinded to the study. Patients were then followed up for 30 days post-surgery telephonically for any symptoms of surgical site infection. Results. The demographic variables such as age, sex, and body weight was comparable in both the groups. The amount of fentanyl consumed was not statistically different in either of the groups. Blood loss, duration of surgery, and hospital stay was also comparable in both the groups. The surgical pathology of the tumor was found to be comparable in both the groups. The TLC, which was done pre-operatively, was found to be within normal range in both the groups in all the patients. The TLC, which was measured 12 hours after surgery, was found to be raised in both sevoflurane and propofol group in almost all the patients. The increase was slightly higher in case of sevoflurane group, but the difference was not statistically significant. Procalcitonin levels were measured at beginning of the surgery, before induction, and again at 12 hours after the surgery. Before induction, the procalcitonin level was found to be raised only in one patient in the sevoflurane group. The procalcitonin level measured 12 hours after the surgery was found to be raised in 4 patients in sevoflurane group and 8 patients in propofol group. However, the difference was not found to be statistically significant. The major limitation of our surgery is the small sample size, because of which the role of biomarkers in predicting SSI could not be extrapolated. Also, we could have used more sensitive biomarkers like interleukin-6 and TNF-alpha, but again, because of the paucity of the funds, this could not be done. Discussion. There was increase in total leukocyte count in the post-operative samples of almost all the patients. Although the procalcitonin value was raised in 8 patients in propofol group as compared to the 4 patients in sevoflurane group, but the difference was not statistically significant, and also there was no evidence of surgical site infection in any of the patients. The duration of ICU stay and hospital stay was also not increased in either of the groups. To conclude, in this preliminary study, there was no incidence of surgical site infection in any of our patients in either of the groups. Hence, there is a need to conduct a large multi-centric trial. At last, we would like to thank ISNACC for funding our study project, and a special mention to Dr. Ritu Kargar, Zonal Director at FMRI, for subsidizing the cost of serum procalcitonin for this project. Thank you. Greetings from Fortis Memorial Research Institute, Gurgaon.
Questions, please.
Charoo Negi. I'll be presenting our study, Anesthetic Techniques and Infection by.
So Charoo, what do you understand from your study? You've done this study. So what do you gather from here after doing the markers? The markers are not effective in predicting the, the conclusion was very abrupt. You just said that there was no incidence of infection in the post-op. But you end up the way you start the study, no? Like you had a hypothesis in mind. So how do you conclude this now?
Good evening, everybody. Ma'am, actually, this was our pilot study. We intend to do a larger study based on this hypothesis.
No, my question is not that. My question is that you concluded by just saying that there was no infection, I mean, post surgery, you know.
We did not intercept any patient who developed an SSI. Like at our institute, the incidence of SSI in craniotomy patient is around 1.8%.
No. My question is, what was your hypothesis and where do you stand? When you reach the conclusion, where do you stand? You started the study with something in mind, and when you ended the study, the conclusion has to be either that is, that hypothesis was right or wrong or anything else, deviation from there. So where do you come when you conclude the study? Where are you when you conclude? What do you take from this study? The message.
Our initial hypothesis was whether the 2 modes of anesthesia, that's inhalational and intravenous, they per se affect the, they per se have ability to modulate the immunity, and whether it predisposes to surgical site infection.
Okay.
Like as I had shown that in the data that few patients, they had slight increase in the procalcitonin value, but because of the small sample size, they were not statistically different from each other. So at present, we are not in a position to comment whether either inhalational or intravenous form are better in terms of protecting the immune system and body's ability to fight infection. So maybe in future, when we carry out in large number, and in case we intercept the patients who develop infections, and whether they are in inhalational group or intravenous group, or more infections are occurring in inhalational group or intravenous group, and whether they are preceded by the rise in biomarkers, then maybe we'll be in a better position to comment on this.
Charoo, there are 101 other factors on which it depends whether the patient is having infection or not.
In fact, most of them are
Have you
surgical.
negated those factors? Have all your patients gone to the same ward, being looked after by the same set of nursing staff, having the same antibiotic protocol? Are all those factors constant so that you can blame or not blame your technique of anesthesia?
True, ma'am, that surgical site infection is truly multifactorial. We had tried to minimize confounding factor as much as were in our hands, like the antibiotic prophylaxis was standard. We had tried to exclude things which were predisposing, like we had excluded patients who had diabetes or any chronic inflammatory conditions or with previous craniotomy, or who were having pre or post chemotherapy sessions scheduled or radiotherapy sessions scheduled after surgery. We tried to minimize confounding factors. I agree totally with you that it is a multifactorial thing, and totally to isolate this thing will be a challenge. But again, as I'm repeating that we have a plan to conduct a larger study, then maybe we'll have some answers about it.
Right. Thank you.
We'll have to move to the next speaker.
Thank you so much.
Next speaker, please.
A very good evening to all of you. The title of my study is the comparison of intraoperative propofol dexmedetomidine and ketofol dexmedetomidine infusions on recovery from anesthesia in patients undergoing endoscopic transphrenoidal pituitary surgeries. Pituitary adenomas are common brain tumors with prevalence rate of 10 to 22%, and the transphrenoidal approach is the preferred for resection of pituitary tumors. After the transphrenoidal surgery, the emergence should be rapid to permit early neurological examination, and also should be smooth, as the cuffing can lead to bleeding, CSF leakage, and dislodgement of the nasal grafts. Therefore, the short-acting anesthetics are preferably used in these surgeries. The aim of this study is to compare the effect of propofol dexmedetomidine and ketofol dexmedetomidine on the recovery from anesthesia in patients undergoing endoscopic transphrenoidal pituitary surgeries. The primary outcome of this study is to compare the time of recovery from anesthesia in both the groups. And these are the secondary outcomes. Ours was a prospective double-blinded randomized study, and the sample size was calculated using a previous study, and which came out to be a total of 40 patients, 20 patients in each group. The patients aged between 18 to 65 years, ASA 1 and 2 patients of either sex undergoing transphrenoidal pituitary surgeries were included in the study. And after obtaining the informed consent, a standard anesthesia technique was followed for all the patients, where the patients were induced using fentanyl, propofol, and vicuronium. The maintenance of anesthesia was done as per the group allocation and was titrated to maintain the BIS in the range of 45 to 55. In the propofol group, we used 1% propofol at a dose of 0.6 to 0.9 ml per kg per hour, and in the ketofol group, we combined ketamine and propofol in a ratio of 1:5, and this drug was also infused at a rate of 0.6 to 0.9 ml per kg per hour. Also, in both groups, we used injection dexmedetomidine infusion, which was made in a ratio of 5:1, and this was infused at a rate of 0.1 ml per kg per hour to maintain hypotensive anesthesia, and the MAV was maintained within 25% of the baseline limits. Intraoperatively, the hemodynamics of the patient were noted, and we also noted the recovery time, extubation, and the emergence time. The cuff score, sedation score, modified Eldred score was also noted. A short orientation, memory, and concentration test was performed. After extubation, the quality of the surgical field was assessed by the operating surgeon using the Likert scale, and the post-operative pain and the post-operative nausea vomiting was also assessed. A total of 48 patients were assessed for eligibility, of which 41 patients were randomized into the propofol and the ketofol group, and 1 patient was excluded from the propofol group, and so 20 patients were analyzed in both the groups. The clinical and the demographic data of the patients in both the groups were comparable, and there was no significant difference in both the groups. The intergroup comparison of the preoperative hemodynamics between the two groups was also comparable. The difference in the mean heart rate on the patients in the two groups was also not statistically significant. However, the mean arterial pressure in the ketofol group was significantly higher than the propofol group at 90 minutes, 120 minutes, 130 minutes, post-intubation, and also during the cellular dissection. The NRS values of left side and right side were also comparable. The propofol used for maintenance in the ketofol group was significantly lower than the propofol group, and also the pain score was also significantly lower in the ketofol group. Coming on to the recovery, the emergence time, extubation time, and the recovery time, all the three were prolonged significantly in the ketofol group. However, the cuff score was better in the ketofol group. The agitation score, modified Eldred score, the cognition and memory test, Likert scale, and the incidence of post-operative nausea vomiting were all similar in both the groups. Coming on to the discussion, the systolic, diastolic, and the mean arterial pressures were higher in the ketofol group. Similar results were obtained by Maheshwari et al., who used ketofol 1:5 ratio, which was used for the maintenance of anesthesia in traumatic brain injury patients undergoing decompressive hemicraniectomy, and they found out that the patients in the ketofol group had higher MAP. The requirement of esmolol and the propofol boluses in our study was slightly higher in ketofol group than the propofol group, but the difference was not statistically significant. The difference in the NRS values of the two groups was statistically not significant. There were cerebral desaturation episodes in 3 patients, 2 in propofol group and 1 in ketofol group. This could be explained because the ketofol group had higher MAP values as compared to the propofol group. Similar results were obtained by Farzanegan et al., who studied the NRS values in 41 patients undergoing hypotensive anesthesia, and they found out that 7.3% of their patients had cerebral desaturation. The emergence time, extubation, and the recovery times were also longer in the ketofol group than the propofol group. Similar results were found by Syed et al., who used BIS-guided sedation with propofol and ketofol, and found that ketofol caused prolongation of the recovery time as compared to the propofol group. These results were, however, discordant with those of Solomon et al., who used propofol and ketofol for sedation in pediatric populations. They, however, found that the recovery time was rather longer in the propofol group than the ketofol group. Phillips et al. Compared propofol and ketofol procedural sedation, and they found out that patients in the ketofol group experienced cold sedation at significantly higher BIS scores as compared to the propofol group. Therefore, the higher BIS scores in the ketofol group might have provoked the overinfusion of the study drug, which further contributed to the longer recovery times. The patients in the ketofol group had favorable cuffing scores as compared to the propofol group, and this difference was statistically significant. Mohammed et al., they conducted a study to compare the extubation characteristics of the patients induced with ketofol and propofol in the patients who were undergoing laparoscopic drilling of polycystic ovaries, and found that the ketofol group had better cuff scores and had a smooth extubation. Similarly, Safavi et al. Compared the effect of small doses of propofol, ketamine, and ketofol to note the presence of cuffing during the extubation, and they found out that the ketofol group had the minimum cuffing score. The pain score was also lower in the ketofol group than the propofol group. This could be explained with the synergistic anesthetic and analgesic effect of ketamine and propofol. 3 patients out of 40 patients complained of nausea and vomiting. Out of 3, 2 were in ketofol group, 1 in propofol group, and these results were similar to the results which were obtained by Chaudhary et al., and who found out that there was 6.7% incidence of post-operative nausea vomiting after the transsphenoidal endoscopic surgery. To conclude, the patients in the ketofol group had higher mean arterial pressures and better pain control, and we also found that although the recovery from ketofol anesthesia was slightly delayed, but the quality of emergence was good, as the patients had better cuff scores. Thank you.
So again, I'll ask you, what is your take-home message for this presentation?
Intraoperative propofol dexmedetomidine. And the hypothesis of this study was because we found some studies that they showed that the ketofol had a recovery profile which was better as compared to the propofol in terms of the recovery time as well as the cuffing scores. But in our study, we found that even though the cuff scores and the sedation scores were better in the ketofol group, but it led to some substantial delay in the recovery of the patients.
So what is the clinical implication of this for the general masses?
This ketofol can be used as an alternative to propofol, but again, the concentration and the drug dosage has to be decreased if we want better sooner emergence in these patients. Because we used it to target a BIS of 45 to 55, and we also saw that the ketofol patients attain sedation levels at BIS levels which were higher. So we thought that maybe because of that, we used more of the study drug, so which led to a delayed recovery in these patients.
So would you suggest targeting a lower BIS? I mean, not increasing your doses when you see the BIS is higher?
Yes, ma'am.
But the sedation has to, the score has to be based on BIS only. So how do you think that ketamine alone was responsible for increased BIS value if we have used a similar group, similar amount of drugs?
So in propofol group, we used propofol only. In ketofol group, we used a mixture of ketamine and propofol.
Yeah.
So correct. But if the BIS values have been same, you have tried to maintain the BIS value same, but you could not maintain in the ketofol group.
No, sir, we could maintain, we targeted it in a range of 45 to 55, but what we want to say is that because we wanted to keep it in the target range, which could have led us to give more of the anesthetic agent.
No, but if more is required, see, the target is BIS. If BIS is like that, and if it needs more drug, it needs more drug.
To give you more drug.
It's not that you gave more drug. How do you know this is more or less? More or less is defined by the BIS. The BIS decides for you whether you are giving 10 ml is sufficient or 20 ml is sufficient for anything. It is the BIS. So if your BIS is fine, if it's same in both, then how can you say you gave more drug?
Ma'am, that's what I'm trying to say, because in some studies we have seen that when we compare one clinically the sedation score and one is the BIS guided score. So there have been studies which suggest that the ketamine and the ketofol, both the patients can achieve a good level of clinical sedation, but still the patient will be showing higher BIS values.
So when you do a scientific study, you have to have a parameter. You have to follow your doses with something scientific there. No? So you picked up BIS in this case.
Yes.
And when you're picking up big BIS in both the groups, then how do you attribute it to your increased dosing? I don't know why you say increased dosing, because the dosing is adequate to the BIS, So you're attributing it to giving an explanation for one group and not giving for the other group. I mean, I didn't get it. I mean, I'm sure others have got it, but I haven't got that.
Yeah. We have to move to the next.
Yeah. Okay.
Next speaker, please.
Ramamani.
Good evening, everyone. I'm going to present my study comparing the two techniques of performing an epidural blood patch using an epidural catheter on clotting time, clot retraction, and hemolysis. It is a prospective in vitro study. Background. Spontaneous intracranial hypotension is a syndrome that results from spontaneous CSF leak which happens at the spinal level. This leak can happen at a single level or at multiple sites. Because of the continuous CSF leak, patients often present with low pressure headache with postural variation. This low pressure can cause traction on cranial nerves and meninges and other structures, which can result in nausea, vomiting, vertigo, diplopia, blurring of vision, and tinnitus. CT myelogram or MRI T2 weighted images with a thin slice cuts are taken to locate the level of the leak. Once the level of the leak is located, these patients are initially managed conservatively using an analgesic, bed rest, and hydration. Those who fail to get treated with conservative management, epidural blood patch is given. Epidural blood patch is a technique in which the autologous blood is injected into the epidural space close to the leak or at the site of the leak using a Tuhi needle. When we give a blood into the epidural space, it forms a firm clot, thereby it seals the leak, or it works by volume replacement principle.
Sometimes it is impossible to perform an epidural blood patch using a 2E needle, so we have to use an epidural catheter. For example, patients with a high CSF leak in cervical or upper thoracic region, or patient who has a multiple level leaks, or patient who had previous spine surgery. In pediatric patients and patients who are uncooperative, we need to use an epidural catheter. When we use an epidural catheter, we usually draw blood in a 20 cc syringe and we'll inject it through the catheter. It takes about 8 to 10 minutes to inject the blood via the epidural catheter. By this time, the clotting starts to occur in the syringe or epidural catheter tubing itself, which causes consumption of all coagulation factors that will affect the clotting efficacy of the unclotted blood too. This prolongs the clotting time, and also it does not provide a firm, fresh blood clot. Thereby, the seal may not happen as effectively. Also, injecting the blood using a 20 cc syringe, it involves high pressure. This high pressure can cause hemolysis, which can also affect the clot quality and clot retraction. So we are hypothesizing that drawing a smaller volume of blood using a 5 cc syringe and injecting the blood as quickly as possible will provide the fresh blood into the epidural space with the maximum clotting factors, thereby helps in forming a firm clot. This study is a prospective observational study which was performed in the blood bank after the ARB and CTRA registration. Healthy adult volunteers aged above 18 years with a normal complete blood counts were included. Volunteers with anemia or thrombocytopenia or red cell membrane disorder or platelet function defects were excluded. From 5 healthy voluntary donors, the complete blood count was taken, and after making sure that the hemoglobin and platelets were within normal limits, they were included in the study. In the 20 cc syringe technique, under strict asepsis, 20 Gauss scalpel set was inserted and 20 cc of blood was collected and injected into the epidural catheter immediately. As the blood flew out of the epidural catheter, 1 ml of blood was collected from the tip and at the beginning and also at each minute interval. Total of 4 samples were taken. In the 5 cc syringe technique, from the same volunteer under strict asepsis, 5 cc blood was collected by direct venipuncture and blood was injected through the epidural catheter. As the blood flew out of the epidural catheter, 1 ml of blood was collected from the tip at the beginning and at the end. Totally 2 samples were taken. The following parameters were compared between the groups: the time taken for injection of blood and the whole blood clotting time, which was calculated using a standard method. And the clot retraction also was compared between the groups. This was done using visual appreciation. And the hemolysis also was compared by measuring the plasma-free hemoglobin using a HemoQ machine. And this is the table which showing demographic and baseline HB and platelet of the voluntary donors. 5 male healthy voluntary donors were selected. The mean age was 25 years with a BMI of 21.3. And the baseline HB hemoglobin was 15.9 grams per deciliter. Their platelet count was 284,000 per microliter. And if we looked at the injection time, it took 80 seconds for the 5 cc syringe to happen. And it was 272 seconds for the 20 ml of blood to go into the epidural catheter. This implies that the 5 cc syringe technique helped in depositing the blood into the epidural, depositing the blood as quickly as possible. And when we looked at the clotting time, it was about 12.27 minutes in 5 cc syringe, and it was 14.54 minutes in the 20 cc syringe. If we compare the graph on the right side, which shows that as the blood was collected immediately and 1 minute, 2 minute, and 3 minute interval, the clotting time was slowly progressively increased. When compared to the 5 cc, there was no increase noted. And then when we looked at the hemolysis, it was actually measured using a plasma-free hemoglobin. It was actually comparable between the 2 groups, which implies that there was no hemolysis noted between the 2 techniques. Then we compared the quality of the clot after it retracted. It was actually comparable between the 2 groups. And we wanted to conclude that while performing an epidural blood patch using an epidural catheter technique, using a 5 cc syringe decreased the injection time. And the clotting also occurred early in a 5 cc syringe when compared to the 20 cc syringe. 5 cc syringe technique needed a less pressure to inject the blood, thereby reduce the fatigue. Hence, we recommend using a smaller syringe, 5 cc syringe, and taking the blood and injecting into the epidural space directly or through the epidural catheter will deposit a fresh blood, thereby helps in forming a firm clot which effectively seal the leak. Thank you.
Questions, please.
How do you explain? Sorry, sir. Please
Yeah,
go.
yeah.
No, go ahead, sir. Go
How
ahead.
did you?
Ramamani, it's a very courageous. You people are very bold to get hold of volunteers, to volunteer for an epidural catheter. I think
No.
In vitro study, ma'am.
It was in the blood study. It is not a in vivo study.
Just the blood aspiration was taken from the volunteer, ma'am, but it was performed in the blood bank. It is an in vitro study.
Yeah. See, you mentioned clotting time and all that. You said that every minute you have taken measured the clotting time. Is it really that difference it makes, or how is it? How exactly was it performed? I'm a little bit confused about it.
Yes, sir. So as the blood flew out of the epidural catheter, it was collected. 1 ml was collected in the first tubing, and then till the next minute, the blood was let out. When at the starting of second minute, we collected again 1 ml.
Okay.
So when we injected the blood into the tubing, from that is the starting point, till the blood started to clot. Every 30 seconds, they have just taken the tubing and just tilted and checked. So from the time point, it is aspirated and it came into the syringe to the time of forming a clot. This was counted as a clotting time.
Okay.
That is why, yes.
So the clot formation was noted visually, was it?
Yes, sir. Yes, sir. Every 30 seconds, the tube was tilted till it failed to, dip into that side. It was taken as a clotting time.
How do you explain it, Rama?
And ma'am, what we felt is 2-3 cases where we have to do an epidural blood patch using a catheter. I felt actually usually I take a blood in a 20 cc syringe and I start injecting. When I did that, I felt extreme pressure is needed to inject. Then I thought whether this one patient had a good complete resolution, the other patient had a complete, still he had a slight headache was there. So I thought whether is this blood is, am I using an excessive pressure? Do I need to check it? Then I myself donated and checked myself. And there was actually the hemolysis was a little bit prolonging when I injected through that. And also I have noted as I injected in the syringe itself, the blood started to clot. Then when I discussed with the physiologist, then they said, see, as the blood goes into the epidural space as fresh, then the clotting factors remains, more, and it will form a firm clot compared to this. Then we thought, okay, we will just do this study, though it is, we won't be able to do it in vivo. We thought we will simulate and do and see whether the clotting time, as I mentioned in this 20 cc syringe technique, the first sample took 12 minutes. The last 3-minute sample, it was almost like 17 minutes as compared to the 5 cc syringe, where I have taken the blood sample using a small 23 gauge needle, ma'am. If I could have used a 20 gauge needle, even I could have deposited faster. Hence, the clotting time could have been even more better. So I feel after this study, I have changed my practice where I perform even using an epidural 2V needle. I started to use a 5 cc syringe. As I'm going to inject, I will collect the blood and the fresh blood will go. Within 15 to 30 seconds, the blood will reach the epidural space. So we are hypothesizing that fresh blood will form a firm clot compared to, because the clotting efficacy is the main key factor forming a seal. So we thought this is the best compared to the
efficacy. I think from the point of view, it is fine that the explanation holds very well, that you put in quickly, you put in the blood and the clotting factors take action. But when you're using it in vitro, then you have a 20 cc syringe and you yourself said it starts clotting within the syringe only, like the blood is still there in the 20 cc syringe. Won't the clotting start right away? Like in the sense, this blood is still traveling in that 20 cc syringe. compared to, I mean, till it reaches the tip? I mean,
Yes, ma'am. As it goes towards 17, 18, the 20 ml, actually it's a little higher pressure is needed to push the blood. We could push the blood, but there was a very lot of pressure was needed. So we were wondering whether that is causing hemolysis. But when we did this, it didn't cause so much of hemolysis, but it did exert a lot of pressure on the hand, and it was very difficult practically to do the injection as quickly as possible.
Like the blood to travel up and down, so that you don't know the exact site of the puncture. So the blood should be allowed to travel a little up and down. Unless it's liquid at that point, will it travel up and down? It will just stay in one space.
No, that is why, ma'am, in a patient, actually, when we perform, we are actually most of the time we are performing a targeted epidural blood patch. So wherever the site of the leak is identified and it is performed. But in a patient who's where you do not perform, it's like a multi-level leak where you use a 2He needle at multiple sites and you will inject so that the blood will travel. But when you perform a targeted thing, it's better to deposit the blood in that particular site. So it's better to put the catheter, locate the space level of the tip of the catheter using a contrast, and then you perform the thing. Then it will be better seen, especially in an uncooperative where patient had previous surgery, where you don't want to, go directly with the epidural needle and puncture the dura because the dura is already stuck with the outside tissue. So that's why we thought we will use this technique. So we have done it also to 3 patients, and I thought I'll just do that.
Thank you. We have to move to the next speaker. Next speaker, please.
Thank you, ma'am. Thank you, sir.
I'm Dr. Shyamala, Senior Resident from NIMHANS. I will be presenting a study titled Cardiorespiratory Complications during Magnetic Resonance Imaging in Neuropsychiatric Patients. Cardiorespiratory adverse events are more likely in neuropsychiatric patients due to the inherent nature of the disease process and possible airway compromise. Data which is available are mostly retrospective in nature and focused only on children. The primary objective of our study is to estimate the incidence of adverse cardiac and respiratory events during MRI in patients requiring anesthesia services. And the secondary objective is to identify the risk factors predisposing to such events. Materials and methods, it was a prospective study conducted in our institute from March 2020 to September 2021 in neuropsychiatric patients. And patients who refused consent or COVID positive patients were excluded. The conduct of anesthesia was as per the discretion of the attending anesthesiologist. Data was collected from anesthesia record, and any cardiorespiratory adverse event and interventions were documented. These were the adverse cardiorespiratory events studied. Statistical analysis was using R software. Interval and ordinal scale variables were represented as mean and standard deviation. Nominal variables were represented as frequency. The association of interval scale outcomes were using linear regression, and association of nominal outcomes were using binary logistic regression. Correlations were conducted using Spearman's rank correlation with a p-value less than 0.05 being statistically significant. Coming to the results, these were the age and gender distribution of the study patients. And this is the distribution of diagnosis in our study patients. Demographic data showed higher ASA physical status, increased number of risk factor count, and slightly longer recovery time in adults compared to pediatric, whereas better recovery OASS and PSU discharge score in pediatric patients. Anesthetic technique showed higher use of pre-medication in pediatric patients and preferential use of dexmedetomidine as induction and maintenance agent in adults, whereas propofol being used in pediatric patients. Coming to respiratory adverse events, pre-existing illness was noted in 14 adults and 2 pediatric patients. The incidence of respiratory complications in adults was 3.69%. Incidence of airway obstruction was 3.29%. 0.99% desaturation, and apnea and bronchospasm incidence being 0.099%. Out of 37, 32 patients required airway intervention in the form of nasal or oral airway, LMA or tracheal intubation. Incidence of respiratory complications in pediatrics was 2.59%, 2.59% being airway obstruction and 2.39% desaturation. However, there were no apnea or broncholaryngosperm episodes. Out of 26, 20 needed only simple maneuvers such as physical stimulation, head and neck repositioning, jaw thrust, etc. Factors affecting adverse respiratory events, it was lesser in pediatrics, lesser in neurosurgical compared to neurology patients, and in patients who required no induction agent. And it was more in patients with higher ASA physical score. Coming to cardiovascular adverse events, pre-existing vasopressor requirement was 7 in adults and 0 in pediatric patients. The incidence of adverse cardiac events was 3.69% in adults, 2.9% incidence of bradycardia, 1.29% incidence of hypotension, whereas the incidence of cardiovascular complications in pediatric was 0.49%, 0.39% incidence of bradycardia, and 0.099% incidence of hypotension in pediatric. Symptomatic bradycardia occurred only in 1 adult requiring intervention. Hypotension in all patients were treated with vasopressor bolus or titration of ongoing infusion. The other patients with bradycardia were, however, hemodynamically stable and hence only observed. Coming to factors affecting all adverse cardiovascular adverse events, it was less in pediatric patients, less in patients who received propofol, and more in patients with pre-existing vasopressor support and with higher ASA physical status. Coming to factors affecting cardiovascular events requiring intervention, it was again less in pediatric patients, less in outpatients compared to inpatients, and in patients in whom pre-medication were used. And it was higher in patients with higher ASA physical status, higher in patients with pre-existing vasopressor use, and in patients who received inhalation agent for maintenance compared to dexmedetomidine. Coming to respiratory complications, it was lower in children, probably due to better assessment and optimization prior to administration of anesthesia. Higher ASA grade correlated with respiratory adverse events, whereas pre-existing respiratory illness did not. Patients who received monitored anesthesia care and intubated patients had lower adverse respiratory events. While looking at the previous studies, which were predominantly retrospective in nature, it showed that common respiratory adverse events include airway obstruction and desaturation, and to a lesser extent, apnea, hypoxemia, or need for respiratory resuscitation. Higher ASA physical status and pre-existing respiratory illness have been shown in some studies to predispose to respiratory complications. Coming to cardiovascular complications, bradycardia and hypotension were again lower in children, probably due to better optimization and lesser usage of dexmedetomidine in children. And pre-existing vasopressor support and hemodynamic compromise increased the risk. Use of inhalation anesthetics, probably due to their vasodilator property and also due to their use in patients with low GCS who may have had borderline cardiopulmonary reserve, predisposed to cardiovascular complications. Studies have not previously focused on cardiac adverse events in non-cardiac setting. There is only one study which showed an occurrence of 0.7% in children. The strength of our studies is that it is prospective in nature with a large sample size, all age groups included and all anesthetic techniques included. The limitations, however, were that it is a single institutional study performed during a COVID pandemic and only neuropsychiatric population was included. To conclude, the adverse respiratory and cardiovascular complications are higher in adults than in children. And age, anesthetic technique, patient population, ASA grade, and pre-procedural vasopressor support predict occurrence of adverse cardiorespiratory complications. These were my references.
First thing, Shyamala, is that you seem to be having a lot of complications. I mean, you've shown pretty large number of complications. Secondly, what correlation does it have to neuropsychiatry? In your conclusion, it doesn't come back to, it starts off again, the study in neuropsychiatry. So there's has to be some...
It included all neurology, neurosurgery, and psychiatry patients, ma'am. While comparison, it is more in neurology than neurosurgery and psychiatry per se.
Okay. So, like you started off by the study by saying that neuropsychiatry patients are likely to have more of these adverse effects, especially the cardiac ones.
Yes,
So, so is there an explanation for that? Like, why do you have this hypothesis for your study?
ma'am. One is inherently due to the disease process, ma'am. Raised ICP, increased blood pressure. When we subject them to anesthesia, there can be a tremendous fall in hemodynamics and also some amount of airway compromise.
Are you talking about this neuropsychiatry patients, or which kind of patients you're talking about? All neurological?
We have included all three, ma'am: neurology, neurosurgery, and psychiatry patients, ma'am.
Yeah.
So, from what I have shown in the graph, only 58 patients were psychiatry patients. All the others were predominantly neurology and neurosurgery patients.
Yes. So from the title, it appears that you are actually trying to study the neuropsychiatry patients more, and you feel that they could be at a higher risk of complications. But when you end the study, the conclusion doesn't match with any. There's no comment on this. Like, there has to be a comment on what you started with, the hypothesis.
Ma'am, our hypothesis was to include our study population, that is in enhanced neurology, neurosurgery, and psychiatry patients, and see the incidence of adverse events. We've taken both adults and pediatric into account. Adults have not been previously studied. It's all retrospective studies and only in pediatric population. So when we looked at the adverse events were more in the adults as opposed to pediatric, which we never thought of. And probably because we are being proactive and doing everything prophylactically in pediatric, what our adverse events that we have charted is actually lesser than the ones quoted previously in studies.
The cardiac or respiratory events are also depending upon what drug you are going to use, and there is no standardization in the conduct of this one. So how can you say that the incidence is more in children, or because the drugs used in children are different from the drugs which are used in adults?
We have kept dexmedetomidine as a control and compared each agent with it. That is how we have put it across in the factors, sir.
So dexmedetomidine has been compared with ketamine and other drugs.
Yes,
that's
sir.
What you said?
Yes, sir. That is how we have concluded that with propofol it is lesser than with dexmedetomidine.
So we have to move on to the next speaker.
Okay.
Good evening, everyone. I will be presenting my original article titled Cerebral Oxygenation Changes During Induced Hypertension with Noradrenaline in Aneurysmal Subarachnoid Hemorrhage. Pathophysiology of aneurysmal subarachnoid hemorrhage revolves around early brain injury and delayed cerebral ischemia. Delayed cerebral ischemia has been extensively studied in literature, and various complex mechanisms constitute its development. However, the net result is reduction of cerebral perfusion, which results in neuronal death. Optimization of cerebral perfusion through various modalities forms the core of management of cerebral ischemia. And induced hypertension with vasoactive agents is one of the clinical strategies which is employed to improve cerebral perfusion and oxygenation. Noradrenaline is the commonly used drug for this purpose. Various studies in healthy brain has shown that there is no direct effect of noradrenaline on cerebral vasculature. However, the same cannot be told in brain injury patients because of the impairment of cerebral homeostatic mechanisms. So the net effect of the drug depends on systemic hemodynamic status, extent and duration of brain injury, and pharmacology of the drug. So it is important to have an understanding on the effect of cerebral hemodynamics as well as oxygenation before its judicial use. Coming to the objectives of the study, our objectives is to study the effect of induced hypertension with noradrenaline on regional frontal cerebral oxygenation using NIRS and middle cerebral artery blood flow velocity using transcranial Doppler. This study was a prospective observational study conducted in NICU of NIMHANS, Bangalore, and the study population constitutes adult anterior circulation aneurysmal subarachnoid patients following surgical clipping or coiling requiring noradrenaline infusion for induced hypertension. The study was carried out for a period of 18 months. The exclusion criteria include refusal to provide informed consent, pregnant patient, patients with poor acoustic window on PCD, patients with carotid atheroma, bradycardia and arrhythmia, patients with contraindications to noradrenaline infusion, patients who underwent decompressive craniectomy, and patients receiving more than one vasopressor. Coming to the measurement technique, transcranial Doppler measurements were done using 2 MHz probe. Bilateral middle cerebral artery was exonated, and the data recorded include peak flow velocity, end diastolic velocity, mean flow velocity, pulsatility index. This is followed by calculation of zero flow pressure using the shown formula, and this is followed by cerebral autoregulation testing using transient hyperemic response test. Near-infrared spectrometry measurements were done simultaneously during TCD recordings, and this table shows the data which is collected from TCD as well as NIRS as well as the other systemic parameters which are measured. So the time points for measurements include 3, which includes T0 before starting the noradrenaline infusion, which is the baseline mean arterial blood pressure. T1 when the infusion after initiation achieves a 10% increment in mean arterial blood pressure from baseline. T2 when the infusion increases the mean arterial blood pressure to 20% above the baseline. Statistical analysis was done using R software, and interval scale data is represented as mean and standard deviation. Nominal data is represented as frequency and percentage. Within group change in outcome variables was analyzed using repeated measure ANOVA, and between group analysis was carried out using mixed ANOVA. Totally, we screened 58 patients, out of which complete data was available for 25 patients, which was analyzed. This tabular column shows the demographic and clinical data of the patient. And coming to the changes in the hemodynamic as well as ventilatory parameter, there was no statistically significant change during blood pressure augmentation. So coming to the changes in the middle cerebral artery blood flow velocity, in patients with impaired autoregulation with blood pressure augmentation, there was a statistically significant increase in the peak flow velocity, whereas in patients with intact autoregulation with blood pressure augmentation, there was statistically significant decrease in the peak flow velocity. This change is seen in both operated as well as non-operated side, and these changes are seen in end diastolic velocity as well as middle cerebral artery mean flow velocity. Coming to the changes in the zero flow pressure, which is observed during induced hypertension, irrespective of the status of the autoregulation, there was a significant increase in the zero flow pressure during blood pressure augmentation. This change was seen in both operated as well as non-operated side. Coming to the changes in the regional cerebral oxygenation values during the induced hypertension, in patients with impaired autoregulation, similar to the cerebral blood flow velocity, there was a statistically significant increase in the RSO2 values, whereas in patients with intact autoregulation, with blood pressure augmentation, there was a statistically significant decrease in the RSO2 values. This change was seen in both operated as well as non-operated side. So, in patients with impaired autoregulation, induced hypertension resulted in a significant increase in middle cerebral artery blood flow velocity as well as cerebral oxygenation. This is because impaired autoregulation resulted in pressure passive nature of the cerebral blood flow, which in turn resulted in parallel changes in the cerebral blood flow velocity as well as oxygenation with increase in the mean arterial blood pressure. The increase in RSO2 values ranged up to 8.5% and 14.8% from the baseline. These changes are seen in both operated as well as non-operated sites. So, however, the induced hypertension resulted in a significant reduction in middle cerebral artery blood flow velocity and RSO2 in patients with intact autoregulation. This is because in response to increase in the mean arterial blood pressure, there was cerebral vasoconstriction due to intact autoregulation, which negated the effect of the MABP change on the cerebral blood flow. And also, a reduction in regional cerebral oxygenation, though statistically significant in our study, did not result in clinically significant ischemia. But however, we tested this only up to 20% augmentation of mean arterial blood pressure. Augmentation of mean arterial blood pressure to a higher target beyond 28% can result in a risk of cerebral desaturation. Hence, induced hypertension should be done with caution, and additional RSO2 monitoring should be instituted to observe for this change. So, we saw in our study that the zero flow pressure increased significantly with blood pressure augmentation at each time point, irrespective of the autoregulation. And in our study, this zero flow pressure remained within physiological limits, but we did not augment the mean arterial blood pressure beyond 20% the baseline. Augmenting it beyond this range to higher map targets can result in pathological increase in zero flow pressure, which is nothing but a good correlate for an intracranial pressure. So intracranial pressure monitoring to be considered whenever available during the induced hypertension in aneurysmal subarachnoid hemorrhage. So one of the major limitations of the study is we measured the RSO2 values, which gave the level of oxygen delivery, but following brain injury, despite normal oxygen delivery, there may be abnormality in oxygen extraction and utilization. So monitoring these parameters will provide more information regarding the end organ level change during induced hypertension. So to conclude, in aneurysmal subarachnoid hemorrhage patients, induced hypertension resulted in improved cerebral oxygenation only if autoregulation was required. Hence, hypertensive therapy should be done in aneurysmal subarachnoid hemorrhage with appropriate monitoring tools to avoid adverse effects. Thank you. These are my references.
This is your conclusion for the study, but what is your conclusion for a clinical application? What is the message for the common masses, for people who are practicing neuroanesthesia? By this study, have you contributed?
Ma'am, this was an attempt to study the physiological changes which can happen during induced hypertension. Though induced hypertension was recommended traditionally as a treatment to treat delayed cerebral ischemia, as we can see, there are recent developments in literature which forces us to think that is only are we understanding the pathophysiology in a wrong manner, because we have a lot of advances regarding this particular pathophysiology treatment when it comes to delayed cerebral ischemia. So what we wanted to do was we just wanted to attempt to study what happens when we induce hypertension in patients with aneurysmal subarachnoid hemorrhage. So we found whatever findings we was elicited during the study was when there was impaired autoregulation, there is a benefit from induced hypertension. But whereas if the autoregulation is intact, there is no substantial benefit from induced hypertension. So we felt that this will be an added information to the clinicians when they constitute for induced hypertension, rather than blindly giving induced hypertension for all patients.
Okay.
How did you select your patients? What was the criteria for your selecting patients to undergo this study?
Sir, all these patients who received noradrenaline infusion were patients with symptomatic vasospasm. Patients underwent.
They had neurological deficits.
Yes, sir. They have neurological deficits.
What was the effect after that?
So the effect after that was our total sample was 25 patients, out of which 3 patients remained to have neurological deficits, and 2 of our patients developed new neurological deficits. All other patients showed improvement. So out of 25, 20 patients showed improvement, and 5 patients had no change with the intervention.
We have to move on to the next speaker, the last speaker, Dr. Sapna
Suresh.
Good evening. Greetings from Sri Chitra Tirunal Institute. I will be presenting a prospective observational study to evaluate the influence of propofol on eliciting focal neurological deficit using the National Institute Health Stroke Score and somatosensory evoke potential in patient undergoing resection of gliomas. Resection of supratentorial tumors in eloquent areas of the brain has always been a neurosurgical challenge. Moreover, resection of tumors which do not have defined margins has resulted in high risk of permanent deficits as high as 13 to 17%. Neuronavigation techniques, cortical mapping, and awake craniotomies have become the new norm. There have been reports pertaining unmasking of deficits by anesthetic drugs like midazolam, fentanyl, and propofol. However, these have not been objectively evaluated till date. The hypothesis is that propofol sedation will unmask focal neurological deficits when administered in patients with gliomas. And the aim of the study is to know the incidence of these new onset focal neurological deficits in patients with supratentorial gliomas receiving propofol sedation. It was a single center observational study which was done in a sample size of 30. After obtaining IEC clearance, 65 patients with temporoparietal gliomas were screened over a study period of 1 year. And after applying the inclusion and exclusion criteria, chief among the inclusion criteria was that the patient's NIHSS pre-op score should be 0. And the main exclusion criteria was any patient who would not be able to communicate, comprehend, or cooperate with neurological examination. After excluding them, 32 patients were recruited. During the course of study, 2 patients became overly sedated. 2 patients had an OASS of 5, that is observer assessment of alertness and sedation score was 5, that they could not be sedated adequately. And final analysis was done on 28 patients. Now, according to the study protocol, EMLA cream was applied on bilateral upper limb at the areas where subdermal electrode needed to be placed. And the patient was shifted to OT, attached to pre-induction monitors and BIS monitor. Baseline NIHSS and SSEP was obtained of bilateral median nerves. The propofol was started using Schneider model with effect site concentration of 1.5 microgram per ml. And after 10 minutes at T1 interval, when the observer alertness sedation score was 4, that is the patient was lethargic but able to respond to verbal commands, and this was between 70 to 80. That is after 10 minutes, the NIHSS and SSEP was assessed. Then at T2 interval, that is at 15 minutes, the NIHSS and SSEP was reassessed. The criteria for significance was any score change of more than 2, and the alarm criteria in SSEP was any fall in amplitude more than 50% or increase in latency more than 10% was considered significant. This is a pictorial representation of how the study was conducted. This is the Excel Tech machine on which we conducted the study. And this is how the scalp electrodes were placed at FZ, CP3 and CP4, and the median nerve stimulating electrodes were placed. And this is the BIS electrode placed on the forehead. Now, coming to the results, they were all analyzed using the SPSS software, and the sample size had a mean age group of sample population had a mean age group of about 35 years plus minus 8 years, and the population was skewed towards the male side. This is a table showing the trend of physiological variables, which shows that the MAP fell from the baseline at T1 and T2 interval due to the effect of propofol, which was statistically significant but not clinically relevant. Now, coming to the NIHSS score change, any patient who had a score change of 2 was considered significant. So here we can see that 12 patients had a score change of 3 and 6 patients had a score change of 4. That is 18 patients had a significant NIHSS score change. Predominant components of NIHSS which were affected was the motor and the ataxia component. Now, this is a table which is showing that there was a significant fall in N22 cortical response of more than 50% at time interval T1 and T2 in 17 patients out of 18 patients who also had an NIHSS score change of more than 2. And the p-value was found to be significant. We also noted a significant drop in the amplitude, cortical SSEP amplitude at T1 and T2 interval in high-grade glioma compared to low-grade glioma, as evidenced by Fisher exact test and Pearson's chi-square test. The summary of results was that 28 patients were there in our sample, out of which 21 patients had high-grade gliomas, of which 18 patients had more than 2 NIHSS 2 score change of more than 2, of which 17 patients had reduction in cortical SSEP amplitude. High-grade gliomas developed a change in NIHSS and associated fall in cortical N22 amplitude on the tumoral side. None of the low-grade gliomas resulted in a fall in cortical amplitude. Now, coming to discussion, our study showed that the use of propofol sedation in patients with temporoparietal high-grade gliomas resulted in unmasking of focal deficits, which was comparable to the study conducted by Lin et al. But in our study, we also obtained objective corroborative electrophysiological evidence with SSEP. The proposed mechanism is in the perilesional area around the tumor, there are large amount of neuroplastic changes that start occurring due as a compensation for the cortical function. These neuroplastic zones are extremely sensitive to the GABA agonists. and does result in unmasking of deficits. There is also increased uptake, delayed washout, and hence more liability for metabolic suppression in the perilesional area due to brain remodeling, which acts as an additive effect. The relevance of our study is propofol sedation can be is used in widely in scenarios like awake craniotomies, where the neurological deficits are continuously assessed. So the anesthesiologist and the peri-op physician should be aware of this unmasking effect of propofol, as it can potentially confound the neurological assessment of patients in these scenarios. As evidenced by our study, NIHSS has a good correlation with SSEP, so it can be used in resource-limited setting to screen for such focal deficits. Limitation of our study was it was a single center study and it did not check for reversibility of unmasking of deficits after stopping propofol. Conclusion is that the propofol causes unmasking of neurological deficits in patients with high-grade gliomas. Hence, the anesthesiologist and the neurosurgeon should decide on the extent of resection, giving due consideration to this effect. Further multicentric trials are needed to strengthen our evidence. Thank you.
Questions, please.
Yeah, this unmasking is how much does it bother you? Like when you're doing awake craniotomies in your center also, no? So clinically, how does it correlate? Do you feel that, I mean, in a clinical setup when the neurosurgeons are resecting, that is what you said, that you have to be aware of and you have to kind of be careful at that time that you may be getting a more neurological deterioration than there is actually is in the patient. So do you think clinically it is like being seen in your setup or any other setup, or is it more of a theoretical concern?
Good evening, ma'am. Actually, we did not do it in patients who are planning to undergo awake craniotomy. We did it in patients with high temporoparietal gliomas. And when we did this assessment after starting sedation and when we reached a particular level of sedation, when we did the NIHSS scoring, we found that there was a score change of more than 2, which I think is clinically significant, because when we are doing, when we take a patient who in awake craniotomy, propofol is one of the most commonly used drugs which are seen. And even though we know that its context sensitivity half-life is quite even though the literature says that it is between 2 to 8 minutes, according to Peck and Hill, they have said that the maximal context sensitivity half-life of propofol can be as high as 20 minutes. So if we go according to that, and considering that the patient will be on quite a bit of infusion till we stop it during the assessment of neurological deficit, we have to be careful of whether it is the drug effect or whether it is the effect which is caused due to surgical resection. And as evidenced by my study, we also gave an electrophysiological evidence that there is a fall in the cortical response on the tumoral side when this.
Practically, what you suggested that now that you whatever you gained from this study, do you have a solution for the some suggestion for the anesthetist and the surgeon? Based on
One is, ma'am, propofol should be stopped for adequate amount of time, and we can use this NIHSS scoring if if people don't have SSEP in their setting. We can use NIHSS and see for the reversibility. Our plan in the next part of the study is to use propofol in awake craniotomy patients and to check for reversibility of these focal deficits that are occurring after giving propofol sedation. One is that, ma'am. Second thing is that we can use drugs like dexmedetomidine, which act at a subcortical level, which will prevent these unmasking of deficits that occur. And in my parent study in Lin et al. Also has suggested that dexmedetomidine has lesser unmasking of focal neurological deficits when compared to propofol, midazolam and all, which are GABA agonists, which they say that these the neurons are more the newly formed synaptic connectivity is more susceptible to these GABA agonists like midazolam, propofol, etc., rather than dexmedetomidine. So,
Sapna, I just wanted to ask, if there is a deficit, you are unmasking it. That means it has been there, but you have not either been able to see that clinically or otherwise. Why do you think it is bad?
No, verification. That is what I was about to say. That if it is unmasked,
you have unmasked the neurological deficit, so which was not recognized.
That is to My
Yes.
So,
benefit.
sir, the NIHSS pre-op NIHSS score of all these patients baseline was 0. I have assessed them personally pre-op.
No, I am
They
not
don't-
asking that. Yes, correct. You have assessed the NIHSS score and you have found that with propofol the score has decreased, or you have got it 2, 4, something, whatever it may be. But
So I have
it
to be
means to
careful.
say that patient did have the deficit which was recognized only after propofol. Is that,
Sir,
or
but
you have anything else to say that?
no, sir. It's just that in cases of high-grade glioma, etc., the extent of tissue destruction is more. So the newer neurons which form this synaptic connectivity to compensate for
That is the mechanism.
function.
I am not asking how this thing is coming
We
up.
can
and all that.
potentially confound the during awake craniotomy. We have to continuously assess the focal neurological deficit and communicate with the surgeon that whether his extent of dissection is.
I would rather do the other way around. Actually, when the dissection has been done, and if there are no deficit, you should give propofol and see whether there has been some deficits.
Exactly,
Because you are not
exactly.
marking the thing. Because whatever has been caused has been found out by giving propofol.
Excuse me, judges. I think we have to close the session. That was a very interesting discussion, though.
Okay.
So yeah, we have come to the end of this Vicky Grover award paper. Thank you, judges. Thank you, Pragati ma'am, Amna madam, Paramashwara sir. Thank you, participants. So we are closing it. We will collect the mark sheets from you and make the merit list. Thank you all. Pragati ma'am, can you please join the hall A now?
I have to join there. Just give me 5 minutes. 10
No.
minutes.
You
Yeah.
take your time, ma'am.
Anyway,
There's no hurry.
No, I'll join immediately,
Yeah,
but I'll
yeah,
give
no.
you the results after that. I have
Okay.
need time to, write.
All the papers were excellent, and it will be a very difficult job for the judges, I tell you.
Yeah, very true. Very true. Okay, thank you all once again. Yeah, thank you.
Okay. Are the judges allowed to
Make comments.
discuss separately or what? If everyone leaves?
No, madam, that is your on you.
Yeah, Indranil, just one suggestion. Subsequently, if you have papers for presentation, it is desirable only the name of the presenter should be there, not the institute or the
Okay,
other
madam.
member.
Okay, madam. Okay, madam.
Yeah.
Okay.
Big bias in that, yes.
Yeah. Okay. Madam.
Okay.
Good night.
Yeah.
Good night. Good night.
I'll give you the results later.
Okay, madam. Thank you, madam.